served on the committee. We've got Sandra Moore, welcome, and Kathy Hadley for the first time. And I think, Paul, this is your first meeting as well. Yeah, hello. Come on in, Pam. You've just made us quorate, so thank you very much. I
did send apologies.
You did indeed. We recognise the fact that there was some traffic issues, so welcome. I don't know, given the fact that we've got some new folk, whether it's worth just going round the room as usual, just to say who you are, who you're representing. I think it always helps to set the tone. So can we start with Ian?
Good morning, Sam Crowe, Director of Public Health.
Good morning, everybody. Kathy Hadley, Corporate Director of Children's Services for Bournemouth, Christchurch and Poole.
Hello, I'm Richard Renaud from University Hospitals Dorset, and I'm representing Siobhan, who gives her apologies.
I'm Pankaj Thavi, I'm Non-Executive Director at University Hospitals Dorset, representing Rob Whiteman, the Chair.
Morning, Amanda Pearson, Chief Constable of Dorset Police. Hi, I'm Liz Bidsall, I'm the Head of Corporate Governance at the ICP.
So we're getting good practice with these microphones. Cecilia Buffton, Chair, ICP.
Good morning, everybody. I'm Paul Dempsey. I'm Executive Director for Children's Services at Dorset Council.
Morning, everybody. I'm Jonathan Price. I'm the Exec Director for Adults, Health and Housing for Dorset Council.
Morning, I'm Councillor Sandra Moore and I'm the new portfolio holder for Communities and Partnerships.
Good morning, Councillor David Brown. I'm the BCP Council portfolio holder for Health and Wellbeing.
Leslie Hay, Vice Chancellor of what now is Health Sciences University, yay. Here representing higher education and in particular Dorset Skills Board.
Morning, I'm Mark Sharman, Voluntary Community Sector Assembly, and in my day job, Chief Executive of Help and Care.
Morning all, Charlie Green, Chair of Dorset BCSA, and my day job is Deputy Chief Exec at Active Dorset.
David, do you want to introduce yourself?
Certainly, David. Oh, which one?
Oh, which David are we after here?
Okay, let's go for David Clayton-Smith first, and then David Sidwick.
Apologies, David Sidwick dived in there. So David Clayton-Smith, Joint Chair of Dorset County Hospital and Dorset Healthcare.
No apologies necessary. David Sidwick, Police and Crime Commissioner. Sorry, I couldn't be there in person. We tried, but the traffic was against me.
Okay. Who else have we got there? We've got Richard.
Just checking if there was another Richard, but Richard Booth, the Deputy CEO and Director of Innovation Adoption within Health Innovation Wessex.
Thank you. Louise.
Good morning. I'm Louise Spate. I'm the manager at Healthwatch Dorset.
Andy. You keep moving. This is not easy.
There are a number of Andys, but I'll go. I'm Andy Purbrick. I'm Joint Chief Executive of Wessex Local Medical Committees.
Thank you. And Andrew Billany then.
Yes, to keep it formal, Andrew Billany. I'm Corporate Director of Housing and Community Safety for Dorset Council.
I can see Simone.
Good morning, Simone Newell, GP in Shaftesbury, Clinical Director for the Vale and representing the Dorset Alliance.
Thank you. I can see Councillor, is it Councillor Jill Taylor?
Good morning, I'm Jill Taylor. I'm the Cabinet Member on Dorset Council for Health and Housing.
Thank you. Councillor Steve Robinson.
Morning, you'll be very pleased to know there is only one Steve Robinson, and I'm
Yes.
a Cabinet Member for Adult Social Care at Dorset.
So is there anyone else online that I've missed? No, okay, and then we've got Sarah Chesel with us. Sarah Chesel. And Sarah, if you want to come and join us at one of the tables here, it might be easier for you. And
Hi, I'm Emma Hoyle. I'm interim deputy chief nursing officer at NHS Dorset, shadowing Karen today.
fantastic. Well, welcome to the meeting. Thank you. Okay, well, so I think we all now know who's in the room, so thank you. Are there any declarations of interest for the agenda items that we have today? No. Okay, can we move straight on then to the minutes of last meeting? So, does anyone have any corrections or any edits or additions to those minutes? No, so can we formally approve them? Okay, yeah, I'm getting some nods. That's great. Superb. Thank you very much indeed. We have an action log, but the two actions are indicated for removal because one's the terms of reference are with us, and the we have the further item on the agenda today. So we're content to close those actions. Thank you. And then we have to look at our terms of reference. Now, the additions to those terms of reference are the Cabinet Member for Communities and Partnerships and the Corporate Director of Children's Services need to be added. Is that correct? And we had to correct the titles of the individuals representing the GP Alliance and the local medical committee. Is that correct? So has everyone had a chance to have a look at the terms of reference, and are we now content that they look correct? Good. Well, that's straightforward. Then we'll have those approved. Thank you. The next item is the ICP work plan, and I think there's a couple of questions that I have about our work plan. Simply, at the moment, we have our priorities coming at every meeting, and it's clear from colleagues in for example, in housing that we won't have a paper on housing this time round. That basically not enough has happened between times. So again, that will come to a future meeting. And certainly we don't have anything on employment or social mobility at this meeting either. So perhaps a plan to look at those items on an every other meeting might be a more sensible approach for the work plan, if we're content with doing that. And the other question I had was around the strategy refresh, Sam, because we have it down as April. But I think one of the concerns that was raised last year was that the strategy refresh felt like it was done to us rather than we were part of it. So should that be brought forward to the January meeting?
Yeah, could you explain the comment that the strategy refresh was done to us? Because I think there was a refresh of the NHS 24 plan, wasn't there? Yes. But I'm not aware that we've formally refreshed the ICP strategy. But I think we should. Yes. And I think it should be inclusive and participative.
I think that reflects really where we need to be with it. So, but April does look like rather too late to bring that to us. So should we put that forward for a January?
If I can have some help, I'll be concerned I'll be right in the middle of disaggregation, and so willing volunteers, and I'm happy to kind of discuss the process, but just being mindful of what we've got in front of us in January. I don't know whether I'll personally be able to deliver that.
Okay. Well, we'll note that and have a discussion outside the meeting as to how we do that. But I think if colleagues feel that they want to be part of that strategy refresh and want to have involvement in it, we need to put some resource behind actually doing that. So, okay, thank you for that. And any further comments on the work plan there? Yes, Miranda.
Chair, I just
press your.
Yes, Chair, I just wondered whether maybe in Q2 or 3 you wanted an update from Right Care, Right Person, as we've talked about it in this meeting, and all phases will be implemented by March 2025. So it may be kind of 6 months in, we want to just have a bit of an update stroke review into this board.
That's a very good idea. Yes, yes, please. Can we add that? Anything else that we want to add to the plan? I know I get in trouble for actually adding stuff to the plan. I know, because we're trying to focus our efforts, we're trying to focus on our priorities, but these are key elements that absolutely, I think, make such a huge difference to the way that we're operating. Okay, well, thank you, everyone. We will take that as being approved with those minor amendments. Super. So the next items was supposed to be Patricia, I think. Is Patricia with us? No. So I think if we skip that next item until Patricia's able to join us, because I don't think there's anyone else who can talk to that item. So supporting the work of ICP, our local authority partners have presented us with a couple of great reports here that actually talk through the work that they have been doing or coordinating or bringing together. So can I ask John to speak first? And who's speaking for BCP is Kathy. Thank you. So, and I think if we can take, the papers, yes, have been read, but I think we need to get some colour out of the papers and what's going on, how that's affecting, working locally, and then we can have a discussion afterwards. Thank you, John.
Okay, it's going to be a bit of a treble act, actually. I think because it's an amalgamation of all of our work, so I won't include Sam at this stage in this paper, but equally it involves Sam's work as Director of Public Health. It might be a bit interchangeable, but got Andrew online as well. So if I just walk through, so we've matched up the paper to the areas of the ICP strategy, so prevention and early help. So the paper talks to some of the work we've been doing with carers, particularly the Bridget online platform, which has been a great success in opening up large numbers of support for carers in a very efficient way. So allowing carers to navigate systems themselves has proved something very positive. So something we're building on further and further as we roll out our transformation. Our work in sort of reablement space with community providers and the Home First Accelerator programme, which was a piece of work specific to Dorset Council, has given us sufficiency of supply out of hospital, which over a number of years has been quite a significant piece of work. So that's also included us trialling bedded reablement offer, which I'm pleased to say we are also taking forward further, and pleased to say that partners around the room are keen on supporting us in that. So lots of positive work there. The work we've been doing around trusted assessment, so really utilising our commissioned providers to help us speed up discharge and onward care planning is something that we're building on. So that sort of trusted assessment feature is something that's been picked up nationally as a good practice. And then, of course, as we move forward, we've just commissioned a piece of work to put around 30 million of capital into building our first reablement centre in Bridport. And we're working with Leslie to help us deliver that model of care, design that model of care, and underpin some of that work with research. So that's very exciting. Pleased that the Council's Cabinet was able to support that work. Hand over to...
Yeah, is development of our Families First for Children Pathfinder. So that's supporting the government to roll out the kind of national transformation of children's social care, the government strategy, stable homes built on love. So there are three, for people that don't know, three Wave 1 Pathfinders, Dorset, Wolverhampton and Lincolnshire, and then now 7 wave 2 pathfinders rolling out the strategies, kind of test and learn approach before the government rolls it out nationally, if they continue to support it. Our model, after a significant period of co-design, went live in June, so sort of 4 months in. Involved in the co-design was all of our partners and children, young people and families. We have Andrea Power from the police and someone called Jill Warren from the health service, who's seconded onto the sort of co-design and implementation team. So very much a partnership design service. And basically the government strategy is to invest in early help and prevention services locally in localities with families to reduce our need to do crisis work, i.e. child protection and children in care work, because I think it'd be really good for families, and probably the Treasury thinks that it will be cost effective as well. So we've been rolling that out. We've had some investment from the DfE to increase capacity, which we've done. So, for example, we've added 14 additional targeted youth worker posts into our service, and more family help workers, etc. We've boosted and made our front door more integrated with family help workers. We're linking it with the community and voluntary sector, and we're investing money in the VCS sector to support them to work with families in the community closer to where they live, so they don't all have to come in to statutory services. We are working with our colleagues in CAMS to bring the CAMS gateway into our social care front door, so that it's just one place that people have to go. We've looked at referrals to CAMS and referrals to children's social care sort of front door over the last year, and a huge proportion of the CAMS referrals actually came to social care front door. So we're looking at joining that up, and I think that will happen hopefully sometime in 25.
Can I just ask you to explain front door, just to make sure
Yes.
that everybody knows what you're talking about there, because I think I do. But...
Yeah, okay. So that's our central place where members of the public or professionals, partners can call in by phone, email. We prefer people to phone. We like this conversation-based front door to tell us if they've got a concern about a child or young person, or to ask for support if it's a family and they need support, or if it's a professional to just to have a chat about support or risk or concerns about a family. So that's how people come there, and then we'll have a conversation with them, and we might signpost them somewhere else, or they might come in to our statutory assessment processes. So very much trying to signpost people to our family help services or VCS sector, if that's the right thing at that front door stage. So a real focus on early help and protection in that space. There are other pillars of the Pathfinder which are about integrated multi-agency child protection service, etc., etc. But key focus of the Pathfinder is to not get there, to do that early support. You will hear a bit more about the Pathfinder, because it encapsulates some of the things later on in the report, but I'll wait for John to carry on through the next priority.
So I was just going to invite Andrew in just to cover off the housing section and the prevention part of the report. Andrew, are you able to come in?
I can, John, but I haven't got access to the paper, so I'm afraid I can't cover it. I'm afraid. Sorry.
Okay, don't worry, I can cover that. So first part really just about how we're managing rough sleeping and those who are, in that position where alcohol, drugs, etc. are part of their daily life, and lots of work that we've been doing to prevent people coming into housing crisis, again through a similar sort of front door model to that which Paul has described. Really pleased that we're opening Gillingham St Martin's extra care site this month. That's a partnership with Magna Housing, our care company Care Dorset, and Dorset Council. That's 55 new homes which are affordable and will allow people to live in the community, supported hopefully for longer. So we're building that pathway through from traditional housing into much more supportive environments for our older people in that space. There's lots of work that's probably Andrew will pick up later around the housing round table, so I won't focus in on that. But also to say that we are putting social workers into our housing teams to try and manage some of those complex cases, and we've been really successful in the last quarter in reducing our use of temporary accommodation. I'm sure Andrew will pick that up further, but that prevention work, getting downstream, is resulting in far fewer people resulting in temporary accommodation, which is great from an outcomes point of view, but also financially. That has underpinned the housing budget in Dorset Council this year. So we are balancing that at the moment, which is very good in comparison to where we were last year. So if I move on to the thriving communities piece, so I'm sure
John, shall I come in at this point? So, apologies to everybody. My system decided to reboot at the point when it's the worst nightmare in these situations. I just wanted to briefly add the point I was going to make around the housing part of this. Is just that it's a bit of a segue for if we do get a slot at the next meeting, we can talk more about this. But we're doing a lot around and good work, I think, around that sort of hospital discharge piece, getting housing officers closer to that prevention of admission as well as discharge. So I think I just want to maybe say more about that when we have more time on housing. I think there's certainly good work there, and certainly the piece, the flag to the work we're doing around the housing round table we discussed last time is about how we link together the various component parts of demand, and that's not just acute end of hospitals, but also around our key worker needs. So just not time for today. We've asked for it to come next time, but that's a decent amount of progress on that from our point of view, and also working closely with Kelly from BCP as well. So good pan Dorset work. Thanks for that. Next time I'll get my system up loaded beforehand.
Thanks, Andrew. So, I mean, thriving communities, I think, Gillian's paper touches on this, but the work that we're doing in the urgent emergency care as partners to drive, a programme of improvement over the next few years has been a significant undertaking for us. We've led the procurement. We will hold the procurement on behalf of the system for this piece of work. But like all partners, we will be putting considerable resource into this programme as it progresses. That's also aligned with the work we're doing in the INT programme. Paul, do you want to say a bit more about that?
Sorry, going to talk about local alliance groups. We've got 7 local alliance groups. I know the paper says 6 local alliance groups. We've got 7th one now that covers Portland, and the local alliance groups bring together professionals and VCS sector leaders together to support programs in the community, individual programs in the community that support children, young people and families. The last couple of years, we've funded each of those local alliance groups to the tune of 100,000 each year to spend as they see fit on good works for children and family in the community. They're chaired independently, those groups, and as I say, they link with the VCS sector, schools and professional services. We're developing a network of family hubs, so we did get investment again from the DfE to develop some family hubs. Lots of local authorities across the country got investment to do that. Paper says we got 6 and we're aiming for 11 sometime early in 2025. As well as those family hubs, according to the DfE programme, they have to meet a whole set of criteria to be a full working family hub. But we have a number of family network points that we're developing as well to add to those family hubs. So they're smaller kind of arrangements with less kind of facilities and being run out of things like libraries and children's centres. Excuse me. So that helps to cover the sort of rurality of Dorset. I was looking online last night in case you asked me any questions about what kind of services are run from those hubs. They differ according to the hub. So if I just read out some of the things I wrote down, so family law, legal advice, midwife clinic, send, play and stay, baby sensory pool, reach drug and alcohol services, citizens advice, under 5s, breastfeeding group, health visitor, baby clinic. I will stop in a minute. Speech and language therapy, music therapy, another breastfeeding group, and there is, and me and Sam are going to talk about more adults kind of focus in those centres as well and work together. But in the Swanage one, if anyone's interested, there is an over 50s table tennis group.
What are you saying?
Yeah. So yeah, family hubs coming on really well. And just say something about our birth to settled adulthood service, which is a partnership between children's and adults and health services. And Cecilia chairs our board, so knows about that. And that is about improving our service for children with disabilities and additional needs. It's about removing that cliff edge at 18 for children. We're not creating another one at 25, which is why we've called it birth to settled adulthood rather than birth to 18 or 25. So we might end our involvement as that service at 20 or 21 or 22 or 25, and in some cases maybe we might need to work with that young person or young adult until they're 26. But you know, someone might reach settled adulthood at 21, just depending on the circumstances. So phase 1, children and adults, has gone really well. We're looking now at developing phase 2, which is health partners coming on board more than they are so far. So that's going well. Lots of work in that space.
Thanks, Paul. Did you want to start with questions? Yeah.
Simone, did you want to come in with a question now? Or do you want to wait till the end?
If I may.
Yes.
Can you hear me? My connection's really poor, actually. I don't know if you can hear me or not, Cecilia.
Yeah.
It was really just an observation of and the amazing work that we've just heard about. And as a GP, you know, I've become aware of the sort of family hubs, the children's hub. But there's never, as you say, there's not been a huge amount of health involvement. And it just strikes me we're going to have quite a lot of work to do as we sort of develop integrated neighbourhood teams in the future. And I think this is a classic example possibly of how services develop in parallel, and how we join the dots is going to sort of solve the working problem. So that was just my comment, really.
I totally agree. I think when we get to the discussion section here, what it is we've got lots of good stuff going on, and that's what we want to showcase here. It's the question is, how do partners lean in? How do they get involved? How do they engage? And I think once we've heard from BCP, we'll get into that discussion, because you're right, it's going to be a big part of our place work as well. So thanks, Simone.
I suppose the final bit to say on here is really you know, the work that we're doing to try and build support for the voluntary community sector. So work Rachel's been doing from public health in looking at thriving communities and what is required to build capacity, support capacity, grow capacity in that space. It's an important building block alongside the work that Paul's just talked about, and indeed, you know, how we as a council move forward through our council plan around the working communities is a big area that we're all involved in designing at the moment. Steve and Jill at the forefront of that. So you know, we're on a bit of a journey here, but these early things are quite important in terms of shaping it. So the final section then, you know, just in terms of working together, I think you know, there's lots of positive work around the DICE and how we're using data across all areas of the council, including our housing data now. So I think we're finding that is becoming more and more a powerful source tool for us. And if we're to believe what we hear about the NHS plan, I think that will be a very important cornerstone of that work. Obviously the work, you know, that can support in terms of the INT work and the work already that's taken place in Weymouth and Portland is really important. Looking at, you know, what role technology can play in some of this work and automisation. Mentioned about the UEC diagnostic, and that was a big piece of work over the summer. So I think not to be underestimated to bring together so many partners and considerable workforce across, you know, what is the biggest part of probably this area over the summer. So really good work and great findings from that. Paul, did you want to add anything on the end?
In relation.
You're just saying this is something we should be thinking about doing more of, I think.
Yeah,
yeah. Seconding people in, not just having them working as teams. Yeah.
Yeah, and sorry, I didn't put my mic on, so sorry for people on virtual. And we're doing lots of work together. Other than that, we have had a adolescent service, Educare in-care service that is a partnership between children's social care, health colleagues, speech and language therapists, psychologists, police colleagues, in that model supporting our adolescents. That's been going for a while. It's called the Harbour Service, and we have a service called Safeguarding Families Together, which is about supporting parents with drug and alcohol challenges, with mental health challenges, and domestic abuse challenges, with adult service professionals working with our child protection social workers. So that's based on the concept that most parents aren't evil, they just have some challenges in a parent, and those are some of the challenges. So if we can help them fix those challenges, they can better parent their kids. So that work's been going for a while now, and it's part of our Pathfinder. We're rolling it out across the whole of our Dorset area. So yeah, thank you. Lots of partnership work ongoing and succeeding.
You're happy. Well, do we want to go and have a listen to the BCP reflections? Oh, sorry, Steve, did you want to come in? Question?
More comment actually. It's really nice to hear some stuff that we're doing, so it's all bundled together, because so often you hear about it in different areas. One of the things that I'd just like to draw out a little bit is we're trying to give increased attention to the way that society is changing. Obviously, we know that everyone is getting older. We don't need to be told that over and over again. But the nature of that cohort is also changing. So we're seeing different groups' experience of aging. So LGBT is now recognised as a much larger cohort than it's been in the past. But there's also other groups like those that are aging without children, which in the next few years is going to number 1 in 5 of the population and still increase. So we need to find ways of reaching those particular groups with specific programs rather than just try to repeat everything that we've done before. And so I just wanted to sort of like tease that out as part of our way forward within Dorset.
Thanks, Steve. I share your view that it's lovely to hear about these programmes in the round and how they're all starting to join up, because actually it's often different committees, different meetings, different responsibilities or silos, whereas actually the need to pull together, as Simone was saying, and then go wider will actually make an even bigger difference. So can we take the report from the discussion from BCP and then come back to a bigger discussion at the end? Thank you.
Thank you very much. It is only me. Gillian Kay, the Director of Wellbeing, is not here currently. So I will be representing, hopefully reasonably well, the adult side of the report. Obviously, I'm going to take it that you've all read the report. It sets out how BCP supports the ICP delivery of the priorities. And I think it's interesting, that discussion about how the priorities might change, because obviously we are wanting to align the priorities from the Health and Wellbeing Board, and I think we need to understand the timeline, I think, from the priorities in January through the Health and Wellbeing Board for BCP, and then on into our place-based partnership. Both the Health and Wellbeing Board and the place-based partnership met this week in terms of determining the direction of travel. And the place-based partnership is very clear. We're moving, strategy into action. So we have become the place-based partnership. We are not talking about the concept of the place-based partnership. And so really wanting to begin to deliver against those priorities through the structure of that governance. And so it would be timely to work with Sam and others about how we do that. And I think we were looking at January for that alignment, but again, working with Sam in terms of how we deliver that against the other public health changes. And so we'll do that. So I'm hoping Sam might be putting me down as a volunteer there, whether I thank you very much. So I just wanted to say, for the purposes of children's, just so people know the distinction in BCP, we are not a pathfinder, and we do not have the resource access that has been afforded to Dorset. We'd love it, but that's not been afforded to us. However, saying that, we have done a number of things that align perfectly with Dorset without that funding and that recognition. So if we think about the early help and preventative arena, we have a children's transformation structure called Building Stronger Foundations. And this is based on the fact within children's, we're on a improvement journey because we had a written statement of action for SEND and an inadequate rating for children's services back in 2021. And so we've had to move significantly from that inadequate rating in the written statement of action. And we have made significant strides in that area. So through that children's transformation, we have already revamped our early help offer. And so we have very much placed that within the community, delivering services to families, redirecting that. There is a real richness to that early help and the offer within that community, and it's how we enhance that and enable our communities to think about their role within that before we get into statutory services. We have delivered, we received a very small amount of funding for our family hubs transformation, and we've transformed 6 of our family hubs, which is where we're going to be. And there's a lot of work that happens in there. I could probably, the same list as Paul outlined in terms of that, there's very much a health focus in that, even down to baby yoga, district nurse, all of that comes into that arena. And we had Andrea Lebson MP come to one of our families hubs and said it was the best family hubs that she'd actually visited. And so we've got a lot of accreditation, but also some real strength for us to then move into how does that get supported wider from that adult? How can we build on that? How can we build that? So also in BCP, we're looking very much in terms of widening it into communities, into the library space, but also in terms of that integrated neighbourhood teams and what that might look like. So thinking across the piece in those areas. In terms of where we were going, we will be moving, for a children's services point of view, into a new service delivery model, which will be a locality based. So again, that aligns and attunes to where we're going in terms of communities, integrated neighbourhoods, and that will be done by April 2025. And we will also be re-establishing the Children and Young People's Partnership in April 2025. And there's been a significant amount of work and partnership work, young people work across the piece in terms of developing that Children and Young Persons Partnership Plan. And so that will then begin to deliver from a multi-agency direction. In terms of adults have a Fulfilled Lives transformation programme. They've got 4 particular areas of project. One is about how they work, so very much in terms of looking at the 3 conversations model and looking at more strength-based ways of delivering services and supporting people at that point. There's short-term support. That's about our reablement services, reducing the need for that long-term service delivery. Self-directed, so thinking about more community-based options, more direct payments, looking in that area, and supporting at home, so thinking about how we get people to stay as independent as possible for as long as possible at home. With regard to housing, there's obviously a new homeless strategy. It's already been referred to, but also in BCP we have a Homewards programme which is in partnership with the Royal Foundation, and so we're aligning those homeless strategy and the Homewards programme, which is specifically around young people and young people leaving care. In terms of thriving communities, what we've been doing is that we've got an age-friendly communities strategy based on the WHO's global network of age-friendly communities. That was delivered at our Health and Wellbeing Board yesterday, and that's also looking at how we support in that area and how we develop our services for age-friendly communities. In terms of our supporting families, we are working alongside our digital programme in terms of making more digital access, self-help in terms of supporting families. Thriving communities, I've mentioned the early help and family hubs. In terms of working together, we have a secondment from health into our commissioning service, which is beginning to develop that relationship. And our integrated neighbourhood programme, we are beginning our engagement with adult social care, public health, family hubs, community service to support that work in Boscombe and in Paul West as we go forward. So that's in a nutshell.
Wonderful. I think what's great is we're hearing the words partnership all the time. We're hearing about trust. We're hearing about, you know, trying to co-design with families, keeping families close to home. So there's a lot that's obviously all going on. And to the point Simone made earlier on, a lot of this is about joining up existing services. We're not actually having to reinvent an awful lot. We're just trying to redesign, join up, coordinate. I don't know how many partners around the table actually knew about a lot of those things. Maybe you were all aware of them all, but certainly I think for me it's been really a rich presentation of all the activities that go on in councils. David.
Yeah, I was just going to add, actually, thank you, Kathy, for sort of presenting the paper and actually summarising a lot of the examples of what's going on. As the chair of the BCP Health and Wellbeing Board that met yesterday in Gillian's absence, I was just going to add to that I think from my position and from the Cabinet's position, that in terms of supporting the ICP's work, a lot of it has been about making sure all of us and decision makers are aware of the ICP strategy and making sure that all our developing plans and strategies are very much in tune with that and pushing in the same direction. There's no point us you having your strategy and our strategies going off a different direction or going in the opposite direction. So very much in terms of our new corporate strategy and vision, picks up on a lot of the points of the ICP strategy, and the refreshed strategy approach that Sam did a lot of work on and that was presented at the Health and Wellbeing Board yesterday. And the recommendations at the Health and Wellbeing Board yesterday were to adopt the main ICP strategy headings about prevention and early intervention, thriving communities working better together, and construct our sort of refreshed strategy to reflect those. So very much pushing in the same direction. We're going to go through a process about a sort of voting process about the most important issues for each of those, and that we're going to have a workshop involving our place-based partnership officers to identify the main programmes anticipated to deliver against the themes in our strategy and the ICP strategy. So very much your strategy is going that direction. We're sort of coming in behind it to push it. Yeah. Sorry. Yeah. And I just wanted to add that from my perspective, looking at all of the sort of various boards I sit on and meetings I have, there's so much movement across the system. In some ways you look at it and it could be quite concerning. You know, we've got and Kathy summarised our BCP Fulfilled Lives Adult Social Care Transformation Programme, and Cabinet have approved £1.8 million to go into that, and more coming in a year's time to actually push ahead with that transformation. The Building Strong Foundations Children's Services transformation going on. So that's our sort of internal transformations. The urgent and emergency care work, which you mentioned, and yesterday we had Newton here to come and present to cabinet members and the corporate management board. So to make sure right at the top level, all of us councillors on the cabinet are fully aware about what work that Newton's been doing and what that work means. All the changes at University Hospital Dorset and the hospital changes that are coming in over the next couple of years, public health disaggregation that's happening, and even internally our Tricuro local authority trading company within BCP is undergoing a lot of changes since separating from Dorset. We're having senior management changes there, changes to their services, and they deliver a lot of our reablement services. So there's a lot of moving parts within the system at the moment across both health and social care, and that could be concerning, but I like to look at it as actually with those moving parts, as long as the right people who understand the ICP strategy and understand our strategies are in right places at the right time, that can actually present a lot of opportunities for our sort of new structures and new ways of working are really in tune with our strategies and with the ICP strategy. So it's quite a challenging time for a lot of people, but I think there are those opportunities presented by all those shifting parts to actually make sure they shift in the correct direction. So.
Thank you, David. That's a really good summary of what was agreed, and also all of the, as you say, the moving parts. I think it's great to hear that councillors are being fully cited on a lot of this work as well, because I think historically that might have been a gap, and now it's really, really helpful to have them cited so they can actively support.
Yeah, and to add to that, it was a conscious decision that we had Newton come in yesterday to talk to the cabinet, because I was aware that a lot of my cabinet colleagues, talk about highways and libraries, etc., etc. But I think it's really important for them to be aware of what's going on in our overall health and care system across Dorset. And I think it really did open a few people's eyes and enlighten people about our part in the whole health and care system across Dorset. And so the detail of what Newton have been looking at and the statistics and their findings. So our cabinet members are fully aware, and I've made a point that paper is going to be going to our cabinet on the 30th of October for cabinet to sort of review where we are and give its endorsement of the way forward, because it's in such a sort of shifting state that we can't sort of say, right, okay, this is the decision, we'll make this decision, and that will then go to our full council in December for ratification, hopefully, of pushing ahead on that work. So not just the cabinet members, but the full council will be aware fully of the health and care system and the changes that we want to make in terms of urgent and emergency care. So, and that's a conscious decision rather than it just being an officer decision behind the scenes, that we make sure it's fully open.
It's complicated, and decision-making processes are complicated as well. I've got David Clayton-Smith who wants to come in, and then okay.
Thank you very much. These presentations were really welcome. And it's so good to hear topics that get discussed in my boards along the same way. So I suppose unnecessary to keep supporting the isn't it good that we're all sort of focusing on the same agenda. A couple of particular things I just wanted to mention, if I may, Cecilia. One is I'm really delighted that the integrated neighbourhood teams is something that we are all embracing. It's very central in health to how we move care, if you like, away from the hospitals and closer to people's homes in the communities, and how particularly how we get partners and primary care involved in that. Interesting too to hear about the experience you've had with the Newton work and urgent and emergency care. Partners will be aware, of course, that we've got in the new hospitals programme, we managed to secure our £100 million for the Dorchester development. And that and the Newton work allows us also to think about the role that community hospitals have in the whole sort of model of urgent and emergency care. Reablement, we are in genuinely good, I think, conversations with colleagues in Dorset Council over the site on the Dorchester Hospital site. It's quite complex, the things that we need to decide, but very keen to continue that debate and very supportive of that care model it represents. Lovely to hear about children and young people in BCP, just to let you know that I've given the special responsibility to one of my non-execs who is an ex-director of nursing, particularly for children and young people. So she's got a responsibility across both trusts, just to have a kind of overview on children and young people, so mental and physical health as well. And finally, the homelessness work in Dorset are very good, because we have the Dorset healthcare homelessness team, and the issues around mental health among homelessness is paramount. And of course, the alcohol normally supports that rather than necessarily being the primary cause. And it's extraordinary, and we kind of know this, that by giving people secure space and homes, how they're able to begin to pull their lives back together. So really welcome to be working hand in hand with those teams. So thank you. It's a really great section. So thank you very much.
Thanks, David. Thank you.
Yeah, thank you very much. Just to build on that, I mean, there's a lot of really good things going on, but we also know that they're connected. It's an integrated kind of system we work in. So how do you, two questions. Firstly, how do you manage the overlaps to make sure that we're not duplicating, because there's only so much resource and finances available, and the more we work together, the better it is for everybody. So how do we manage that? So at the front end versus interfacing afterwards. And secondly, how do we manage to measure the effectiveness and efficacy of some of these things beyond the core area that's dealing with it? Give you an example. We heard about homelessness and we heard about substance abuse. Anything that's done there is, of course, good for the community and the people involved, but it'll be good for the police, it'll be good for the ambulance, and also for the hospitals. So I wonder if there's some way of building some common scorecards or some dashboards that can connect all of us together, so we all know that what you're doing is benefiting others, what we're doing is benefiting you, so then there's some mutual benefit in this.
Yes, please, if we want to address either of those, or Kathy.
So I think the first bit is building awareness. So, you know, today's discussion is really important. We need to do more of that. I think certainly talk for Dorset Council, we've done a lot of strategy rebuild over the last few years, and significantly in the children's space, you know, there is a lot of trailblazing that's happening there. It's quite hard to get a level of engagement on strategy. I've got to be honest, we try really hard, but you know, people are busy, partners are busy, and I do wonder whether there's a little bit of a sort of a conscious effort to sort of take on board some of that strategy build, particularly as it's co-designed. So, you know, everyone's inputs greatly received. But when we do those exercises, and I know Sam will attest to this really with the ICP strategy, it's not always that we're getting people's ear. So I think that's an important bit. I think in our spaces, we have a lot of metrics to the transformation, because Paul's drawn investment from the Department of Health, Department of Education. We haven't. For the work in adults, it's been mainly investment from the ICP, I have to say, in the early days. That clearly has dried up this year and looks very worrying next year. But, you know, how do we address that resource issue, I think, is really important. So I think there's something about sharing a bit more detail, sharing some of the business cases that we're actually delivering.
Can I Kathy come in and then come back to Paul if you want?
Yeah, I think that's a really pertinent question. So as I read through some of all the papers, my question was, how does this not become motherhood and apple pie? What is the actual impact that we're making? What is, and I don't know whether it leads back to that strategy. If we have a strategy, what are the metrics that the board want to look at? You know, as my colleague has already said, there are within our own services, there are a number of metrics that we work to, both from a statutory process, but also from an interested project process, but they may not be at the level that the board might want. But if you think about a metric of, say, obesity, well, what is it that I'm doing in my family hubs, which means that obesity levels are going down? So we do have a outcome framework, a multi-agency against our early help, and so I think it is possible to do that, but I think it is a very pertinent question.
Paul.
Hi, yeah, we do have a strategic alliance which sort of runs our children and young people's plan, and that's all of our partners. So we're coming together regularly to do that sort of strategic work that John was sort of referring to, and we do get good sort of participation and engagement from that. I just try and give two sort of practical examples to address some of those questions that you asked. So the sort of duplication bit, sort of on the ground, that example I gave earlier about our work bringing the CAMS gateway into the children's social care front door. And I said about that when they're separate, we're both taking the same kind of referrals from the same families, which seems like duplication and not a good, not good outcomes for those families from doing that and telling the same story over and over again. Part of the aim of us bringing those services together is to reduce duplication, streamline what we do, and get a better partnership response. So I'm trying to address a bit of that question. The question about metrics, if I use the example of our Safeguarding Families Together programme, which is about adult services professionals in mental health, substance misuse, and the other one, domestic abuse. There is sort of independent research that's been done around the country about the impact of that. So it's good for children if it means that parents are parenting safely and we're not bringing more children into care and we're keeping them at home. But also if it's reducing, and research and evaluation nationally has indicated that it reduces emergency admissions to hospital, it reduces police call outs to families because people are not physically abusing each other. So we've got some metrics about that locally and nationally, and there are a lot.
But I think this is the piece of work that we definitely need to do. It's understanding what are the KPIs that we're going for. What are those outcome metrics? We need models that actually help us define what good looks like, and both from a monetary perspective as well as those softer outcomes, those family outcomes, those people-centered outcomes. I'm going to take. I've got Richard, I've got Ian, and Leslie. Leslie? Yes, by all means.
Yeah, no, thank you. And it was just an observation. Obviously, we're trying to transform into a new way of working and more community-based, and obviously integrated neighbourhood teams. I guess I'm sitting here as a Dorset Skills Board representative, thinking actually where is actually the planning for the workforce around this? How do those links get made? I don't think there's anyone from the Skills Board, for instance, on the ICB People and Culture Committee, for example. So even as a university representative, we tend to kind of go to one place and then another, and actually what does Dorset County need and what does UHD need? We've had meetings, Emma, around that. And so actually, I guess when I sit there on the skills board saying sort of the care worker population vacancies going through the roof, it's dropped a little bit last month, but nevertheless sort of keeping on going up. So I guess that's the only thing. I'm sort of a bit of a word of warning. These are obviously brilliant ideas, but we've got to have in certain areas, even if we're going more digital, perfect, and we've got hubs in Boscombe and that sort of thing. I'm just wondering where we join.
Well, the skills hub and the LSIP work is supposed to be a part of what we're trying to do. The reason for connecting in with them is to raise these issues. Absolutely, how we deal with them, what sort of work plan we need. I think you're right. That's another piece of work. So I again, all of my trying to shorten our work list is just getting longer and longer again, because we do need financial models and KPIs. We need to understand, if we're going to defend this way of working, it has to show that it's evidence-based and that it's delivering outcomes. It will be over possibly different timeframes, but we've got to evidence it.
I'm just aware that in other systems they have that within a people committee at an ICB level, rather than actually it coming through and through and through. So it's how central that discussion needs to be. That's right. I guess is my point.
Take your point. Thank you. Yes. So I've got Richard and then Ian and then Sam. Thank you.
Thank you. Just building on point you just made, Cecilia, and Councillor Brown's point, I think we do actually have and commending Dorset Council for leading the work that Commissioner Newton. I do think that gives us exactly quantified opportunity and a glide path of KPIs as a system. And I'm really pleased how high profile it is in BCP, because that although it's focused on adults, except that in UEC terms, it's the biggest spend for most of our organisations. It's got very quantified what good looks like and what the gap is, and particularly for the acute hospitals as well. our whole plans are predicated on a glide path to improve. Otherwise, in this time next year, plus a month, we might be in a position of having a hospital opening that's too small or the wrong sized. So it's really significant for this partnership, I think, to be able to track those metrics and that glide path. So and we know it's better for our residents to deliver those improved care. So I think all the initiatives are excellent. I think we've also got alongside it now, thanks to the work Dorset Council led on, it is we do have those metrics. So having sight of those and committing to those, I think will make a huge difference to our residents and taxpayers. So probably just checking. I think it definitely fits into the objectives we've got. So I know it's not, hopefully not adding to the list. In terms of the strategy build, the second point I just want to make was around obviously the NHS plan consultations come out yesterday. Look into the national strategy in the spring, I think, sort of April time. So having sight of that and perhaps linking to the work Sam wants volunteers out with, there might be something about getting the timing aligned, because I suspect that's going to come with hopefully at least capital, if not revenue investment and reprioritisation. So I think the strategy build work might again be useful. I appreciate that's an NHS plan, but a lot of it is about population health. So I wouldn't badge it so much NHS as population health. And the final point to say, as we are particularly in UHD going through the service changes, obviously maternity moves next April, and then children's this time next year. We apologies in advance. We might be a little bit inward looking over the next year as we try and manage those changes safely. But partner support on that is really appreciated, and but also perhaps the challenges about not being so hospital centric and making us more locality based. So I found the particular comments about locality working, particularly in children's, one that please hold us to that to make sure we can do our part. Thanks.
Thank you.
Thank you. For me, lots of really good and powerful examples of partners and providers working better together. But for me, working better together involves people and communities. And whilst in the conversation, we've heard lots of examples of engagement and actually having patients and people and the public in the room, if you just read the report, it's hardly referred to at all. And if you think of our strategy being based on going around Dorset and asking people what matters to them, and then building a strategy around that because we listen to them, then that has to be part of every report, the listening agenda. Because I don't want the listening agenda to be something we did at the beginning, then we forget about it. It's something every single partner in the strategy, in the system, has to keep doing.
Thank you, and that's a very good reminder to make sure that we do reflect on that. So thank you, Sam.
Thank you very much for setting up what I was going to say, Ian, because it's a perfect segue. I think this conversation has been really helpful. I wasn't expecting to be asked about the strategy refresh today, which is why I tried to quickly shove it off my shoulders as quickly as I could. But Ian makes a really important point, which is that when we did the consultation and engagement work around the strategy, we did that really careful work, 100 voices, which has been extended. It's now become almost like a routine approach to engagement and listening in communities. Some of you will have been in the Integrated Care Partnership when we did a piece on culture, and we had Professor Alan Tapp come and talk to us about how do you know when things are changing? Is it about measuring metrics, or is it's a bit like the wind? You know, you can feel the wind, but you can't pin it down. It's really hard. So I guess I would just urge us not to fall into the trap of trying to duplicate all of the other places where these big programs are reported on. Yes. We've got lots of metrics. We've mentioned substance misuse. We meet in a separate room through the Combating Drugs Partnership. PCC will be well aware of the close national attention on a whole raft of metrics around how we're making sure that we're providing really good equitable access to treatment and recovery. So I think there's something through this strategy refresh process. It's a conversation about how we capture the really important things that indicate that we are working differently. I do think we need some work on the work programme to pick up on Pankaj's point. It's really important that we use the combined resources of system working to focus on some really important things where we're getting added value from working together. So there's something about trying to sift where neighbourhood and place priorities will be looked after by the new refreshed health and wellbeing strategy, all of the excellent work by public sector partners that will take place through the place-based partnerships, hopefully. But what is it that as an integrated care partnership we can only do by working together at the level of the system? That's where I think we could really have a valuable conversation and populate that work programme so that it's got those essential priorities that no organisation could tackle on their own. And that's what I hope we'll get through the process. So if you'll lean into that, it will be an excellent start to the new year.
Thank you, Sam. And I think you've had a few volunteers already, so I think that is good. Simone, I'll give the last word on this one to you.
Thank you. I think it's along the line of Ian and Sam's comments, really. Just don't keep measuring the same old thing, because it hasn't got us anywhere so far. We're thinking about working differently. We're thinking about care closer to home, thriving communities. So actually we need to be measuring our success there, as opposed to, you know, the typical metrics that we keep on talking about with Newtons as well. So I put in the chat that there's quite a lot of work going on within health at sort of national level, looking at activation measures, both staff and people's activation measures, because actually if people look after themselves, they have less care and health needs, and the same with staff. You know, we saw it on a very small scale when we first started our population health management programme years ago. Actually, staff felt they were making a difference because they were being involved in prevention as opposed to on that hamster wheel of reactive care. So I think it's just a bit of a challenge that we need to think differently.
Thanks, Simone. And I think I've observed that we are thinking differently. We were talking in partnership, we were talking in trust, we were talking about co-design. I think it's how do we actually flesh those out and start to accept those as being our measures of success, as you say. How do we use those? So unless anyone, Kathy, did you want to go? Can we move? Again, okay, a brief comment, please. Can you put your mic on?
From the local authority point of view of supporting the ICP strategy, and we talked a lot about health, social care, children's, but I think for the local authorities it also goes wider.
Yes.
And just to give an example, that I'm quite confident that because of the profile of these priorities across the council, we've got a draft local plan that BCP have approved, and that's going through the process at the moment. And it's got specific policies in there that support things like extra care housing and specialist housing. Yes. There's positive policies about allowing extensions to homes for granny annexes and, you know, multi-generations in homes, and even a specific decision that Cabinet have made this month. The old Bournemouth and Poole College site, we've now approved for 98 homes. That's 76 social rent, 10 temporary accommodation, but 12 specialist accommodation units. So that help with people's care needs and health needs. So I think it's wider across local authorities as well.
It is wider. It is, as other part, Leslie pointed out, it's about our workforce. It's about getting a workforce actually enabled to live here because of affordable homes. It's about developing our economy, you know, making our economy prosperous. It is about being age friendly, but also allowing for, you know, creating places that are vibrant for workspaces for young people who want to come and live here. It is massive. And I think we're doing well to target in there. So, well, thank you. Thank you both to both local authority partners. Thank you very much. That was a great paper, lots of good discussion, and I think as you know, a great partnership working. So thank you. Can I move to Patricia? Patricia, you look like you're at the seaside.
I wish.
We skipped your item, but can we go back to the executive support for the ICP?
Yeah, that's fine. So we've had a reorganisation, a restructure of the senior leadership team in the ICB, and David Freeman is now a full-time deputy chief executive with a number of areas under his portfolio that are directly connected to the ICP, and so particularly around social mobility, which is an area of work that he agreed to lead on behalf of the ICP. Having had a discussion with Gillian and colleagues Matt and John from Dorset Council, we wanted to propose that at least in the interim period that David picks up the executive lead for the ICP. That may well change once we've made permanent or substantive appointments to the 2 directors of public health, but at least for the next few months that David is more than happy to take on that role on behalf of the ICP if everyone else is supportive of him doing so.
Thank you. That is great news. To have that executive support is much needed. Can I just seek is anyone who has any concerns? I think, Patricia, we're all delighted.
Lovely, great. Well, he's on leave, but he'll be very happy when he comes back next week to know that he's supported to do that.
He's fully supported. So thank you very much indeed, Patricia. That's great.
Thank you.
So thank you. So can we move on to our next item, which is a look at our priorities, which was you're looking at cardiovascular disease, respiratory and falls, and then a look at our smoke-free environment. I think actually you can take it as read as partners around the table agree as to why, what our focus areas are and why they are. It's really starting to get into the meat of what's going on, what more can be done, and how we can lean into to support those activities.
Thank you,
So,
Cecilia.
I'll hand over to us.
Hi.
Do you want to introduce yourself?
Absolutely. So for those who don't know me, I'm Ash Boreham. I'm the Deputy Chief Strategy and Transformation Officer for NHS Dorset. And as part of the remit, is the Joint Forward Plan, which I will serve today. And I was asked to bring back some of the priority programmes that we've agreed, which was dealing with CVD, respiratory and falls and frailty. And just to update you on the progress made to date. And as Cecilia says, this is about a partnership and actually servicing those ideas, how the ICP can help support us in this journey. I'm going to share my screen. The deck has been put into your packs, so you've had a chance to look at some of those things, and it will then usually segue into Sam's presentation on smoking cessation and the public health contribution towards these particular areas, including respiratory, which is really key. So I will now share my presentation, and hopefully, Cecilia, I can see you.
Yeah,
we can give me a thumbs up.
Yeah, we can see that. Yeah.
So everybody's aware of the mission that we've got, the end state, which is making tools that health is supposed to live together, and the 5 pillars. And over the time, we've developed the Joint Forward Plan and started to create a number of strategies that underpin the foundations moving forward. And we've created these plans and strategies in partnership with the people in the room. These haven't been done in isolation. And our focus has always been from a population health management approach. The challenges, we know that we have people living longer with more years, but in poor health, and we need to focus on addressing these inequalities. And our approach has always been using the insights, the intelligence and the data to understand the health problems in our environment, to our actions to being proactive and based on healthcare, and really focus on the outcomes. And that message has been briefed before about how we approach our plans for this. And the priority areas that we've said is that, first of all, public awareness and increased patient activation and community engagement, which is why this is so important from an ICP perspective. Managing behavioural risk, understanding lifestyle risk, clinical risk management, and our role in the NHS as a partner, playing our part in when we identify a condition to stabilise it and manage it, and then support that self-care and empowerment of patients through a sustained behaviour change. And what we've done in Dorset is we've established and in some cases re-established the clinical networks led by the Chief Medical Officer and the Deputy Chief Medical Officer, Alison O'Donnell, which is about, and the first ones we set up is respiratory, the cardiology, the aging well, and then working on the diabetes. And these are up and running. And underneath, they're underpinning these is that the number of programs. So in effect, what you've got is you've got the clinical networks are then integrated and supporting the various programs to make sure that they are effectively understood, run, and we get the right advice at the right time. And what we've got is, this is where we see the networks working, is they are in the centre, but we've got system partners from the ICP. We've got a patient experience co-design and system enablers all coming together to integrate into the networks in order to deliver our outcomes. and we have these cross-cutting prevention at scale programs that are also reducing health inequalities. And the areas that we focused on were these priority areas that were set. And these are because they were the most mature networks, and there was a considerable amount of work already being done, but also they will have the major impact on the health and well-being of our population. So CVD Prevent focused on 2 areas of hypertension case and finding an optimization of blood pressure, respiratory disease on asthma and COPD, and aging well, falls and frailty. And the goal for the CVD program review is to reduce premature mortality and morbidity, focus on inequity, and ensure all patients at risk of CVD get equitable care. And the outcomes are reducing the incidence of heart attacks and strokes, improve patient survival and well-being, and address disparities. And it's really important that over 50% of those who suffer heart or stroke are economically active. So this is a direct impact on the well-being and the economic outputs and the well-being of our people in Dorset. And we do that through systemic actions. What we've done is we've prioritised hypertension as part of our local CVD prevention strategies. We've used data to identify and address unwarranted variations. And we've created support primary networks within the primary care networks to deliver these action plans. And the focus of 2024-25 has been around focusing on underperforming and managed hypertension across compared with the national average. So just for the highlight, between 23-24, we were underperforming as a county. We were at 68% and not where we should be. But what we need to do is optimise against a national target of 77%. And what we've done is we've set the target to improve management to optimise an additional 6,274 patients, 6% improvement across the Dorset, reducing variation, and increase the use of BP at home to remote monitoring to an additional 6,000. And on the right of the slide, you will see the trajectory of where we are. But more importantly, what we've done is we've shown the value. So against the number of the ambitions, the number of adverse events we impact on will then produce a number and a value. But more importantly, you can see the impact on the lives saved in this slide. And we use this using a thing called the DK model. And the DK model is very simplistic in that it's data driven. It expands the ability of us to use home blood pressure management, support self-management, integrate additional roles such as pharmacists and healthcare coaches, and developing a community-centered based approach. And it's a really good model that we're applying to all of our programs, which has we identified that of a predictive modeling of what we have through the work we're doing now with the data analytics. We then identify that to the actual population at risk and aware of the problem. We then optimize interventions, and then we have this compliance with the plan. And at the bottom part of this slide, you can see the kind of numbers we're talking about that we're trying to engage with and change. And all throughout this, we're using the population intervention triangle. And this is once again why we need to be working with civic, service-based, community-based centric action. It's really important for us. And then the reality is, for this particular model, the CVD program, you can see the partners involved. And the fact that it is really quite mature. We've now been working this now for nearly 3 years, and we're now improving this program with the teams on the left and the kind of organisations that you're familiar with that form part of our community and our enablers and strength. So the progress today is all 19. Yes, certainly.
Sorry, I think up until this point, I was thinking that things were very, very much done unto the person. But actually, when we get to this model, it starts to look very much more like the sorts of things that we were talking about just now, about how patients feel about the service. You know, does your health condition get in the way of managing your life? Is the sorts of thing, the questions. And this is the area where I'd like to ask colleagues to think about, you know, all of the stuff that's going on in cardiovascular disease management, does it feel like this to the end users? Do they feel that they're being supported in their lives rather than being, again, our paternalistic model of health has just been turned on its head, and it's trying to support, individuals. I think this slide spoke to me of all, of all the ones that you've come to so far as being, yeah, this is what the ICP is about. I can see Sam and then Simone want to come in here if we may.
Just a really quick point. I mean, Ash is right to kind of highlight the importance of finding people with high blood pressure, because it's not something that people generally know that they have until they have it measured and they're told about it. It's a national target, which is why it's been selected as part of the ICB's focus. But the world leader is Canada. So the government targets have been taken from work that's been going on in Canada for a couple of decades now, where they are the sort of most advanced country in the world, if you like, for identifying people with hypertension and making sure it's treated to target. But the clinical work was only a small component of what they've done. And actually, they spent a long time investing in developing proper community champions who understood the importance of talking about blood pressure in different ways, because only a proportion of the population are going to actually rock up and be comfortable seeing a GP or a practice nurse. And it's far, far more important that we understand, you know, what are the barriers to getting full and equitable uptake. And to be frank, the issue in Dorset is the level of variation. There's some excellent practices where nearly 80% of people are identified and treated to target. There are some practices that have much, much bigger challenges with their populations, and you'll find that it's really variation that we need to get into. So I think your point, Chair, is absolutely key. This has to be supported by understanding you know, people's views around hypertension and how we can change as a system to make it far easier to have that genuine partnership in care.
Thanks, Sam. Simone.
Thank you. I'm just speaking from a clinical perspective as a GP that's been involved in some of this work. And I suppose there's two things for me. There's one about actually it would be great if we could get even more upstream so that these people didn't develop high blood pressure, because a lot of it is preventable. So there's that thing that I still think we need to get higher upstream. And I think the other thing is about when we talk about risk groups, and what we're seeing in our area is actually, we haven't quite worked out how do you phrase these, but it's the white working man who is particularly vulnerable and doesn't seek sort of help for his healthcare issues. And we've sort of approached that by starting to go into businesses. So we've been into 2 businesses in Shaftesbury to offer blood pressure checks, and actually we have picked up some uncontrolled hypertension from that. But I think, you know, and talking to Sam's point about variation, it's actually how we do things differently to actually reach out to some of these people that have become the new minority. And it does seem to be in our area, certainly the white working class male, I'm afraid. And we haven't quite come up with a PC version for it, but we're presenting at the Complete Care Communities with James Kingsland, just talking about this in November, and the work that we've been doing in the Blackmore Vale Partnership. So yeah, thanks, Cecilia.
Thank you. I think blokes don't go to doctors, do they, until something falls off. So yeah. Sorry. Thank you, Ash. I'm sorry, I didn't mean to interrupt you, but I think when we got to that side, we were getting into that to the really that what this partnership is about is how do we activate, how do we lean in to support those, and yes, it is about different ways of having conversations, different places to find people. So thank you. Okay.
Yeah, I'll bear in time. I'll just go, because some of the stuff, you know, the key thing is we were asked before that we do understand what's going on. DICE has been developed and continue to be developed. And actually, there is a good news story in this. The work that's been going on, it's not, you know, there's green shoots, as Simone and the clinical team will be telling us. Working with people, what is working is we've moved from where we were to we've moved into a positive position, and the early indications are from some practices, from what we're learning from them in terms of how engaging with the community and their patients, is we're starting to move even faster in the right direction. So this is really good progress. And we're not doing it in individually. We're now taking a population survey to understand more about, as you describe, how we engage with the population, changing behaviours, understanding and working better with our partners. Just quickly go for the respiratory network. This is now being created. On the left-hand side, you'll see the area that we're focusing on at the moment. It's always good to start on 2 key things to start with, and we've said before about asthma and COPD being the ones that we wanted to focus on. But once again, variation. This is a really good slide that shows the challenges about there are pockets of excellent practice in terms of trying to reduce exacerbations and hospital admissions. But you can see this is what's showing the best and the worst performing, and I don't mean in a negative way, of some of our primary care networks, and trying to understand what's working well, because we've now established champions within all the practices to work with those practices to understand what's going on and those differences. And it's really about, as we say, early diagnosis, optimizing treatment, smoking cessation and air quality improvement, which Sam will talk about in a minute, increasing pulmonary rehabilitation, and also making sure from asthma perspective that we follow the guidelines that we've got, evidence-based, and once again, that thematic you talked about, Cecilia, improving patient education and engagement to understand how we could do this. And the next steps is that we've started our initial workshops working with our communities and practices in 3 areas. We've got follow-up workshops to come on. We've got data monitoring, ongoing tracking of outcomes. So we've created the data sets that we know, so we actually know where the problems are, where the impact is, and we're expanding this across all the PCNs to get respiratory where CVD is working very much better in terms of what we've learned from them. What we've done is we've created, and it's in your pack to read, but we've created logic models to help us on our journey. And the next step of implementation is that what we've also done is we've developed new dashboards. Now, this is ultimately, we've worked on trying to reduce demand. So what we've done is create new dashboards to show where are patients coming from into the acutes, into admissions, how many days they're spending, to see and measure the impact, where the differences that we're doing on the ground, and then try and triangulate that. But we've also focused on some early interventions that we can do to try and reduce winter pressures. What can we do now, quicker and faster, to help our people in Dorset? And so we're pushing some stuff really quickly, working with our partnerships, urgent care, and our partners in the system. And the last one I just touch on is the Aging Well network. We've created the network. We've created a clinical lead for it. We are aligning a number of programs that are already in place. Some of these are improvement programs. And we've taken and lifted some models from other communities that work really well. So in this slide here, this is the South West London approach that they've mapped for dealing with frailty. But also, if you look at the area that was interesting is independence and well-being, the front end. That's the kind of that prevention piece where we can start working with our partners, both in the ICP and the third sector, and start to work that through. And we're starting to map this. And what we've done is that we held a workshop with all our partners in Dorset on the 30th of September, and some in the room here attended. We then had the NHS South West Frailty Improvement Collaborative workshop, which held with all systems, including local authority and third sector attended. And there was 12 people from Dorset, from various partners that went. We've established a board. We're starting to map. We're trying to identify based on our metrics and starting to then develop our next steps. I mean, the key thing is about reducing demand in acute and primary care, because we're trying to, for all our things we're trying to do is reduce the adverse effect of these things happening. But actually, as Simon said, we are trying to get upstream as well. We are trying to work in the prevention rather than the secondary prevention space. But the challenge it is that pressure, then all these programs will be cash releasing. But ultimately, in the medium term, we want to reduce those heart attacks and strokes. We want to see the reduction of up to 1,000 unplanned admissions from asthma. We want to see the reduction of up to 581 unplanned admissions from smoking-related COPD. And we want to reduce injuries and falls and unplanned admissions. But also, speaking in the frailty programme, we want to ask the people what matters to them to live independently. What are the things that work? And I'm currently talking to you from one of the creative health conferences being run with system partners now, knowing about other things that can help us to make a change and bringing that into play. And ultimately, this is what we want to do. So the takeaway is that we've got these programs to aim to address significant health challenges. We're aiming to improve outcomes and reduce inequalities. Success depends on sustained collaboration, as you already talked about, resource allocation and rigorous monitoring. And whilst these programs will not deliver cash out, they have potential to reduce unplanned emissions and will deliver that long-term ambition of improving population health improvements for the people of Dorset to live their healthiest lives. I'll stop now. I'll stop my presentation, come back into the room. I am passionate about this, and I absolutely get the message. It is about upstream engagement. So, and conscious of time, I know Sam's following me with the public health side and how we are working together as a team.
Thanks, Ash. I think Ian wanted to come in.
Thank you. I mean, a magnificent piece of work. I can't find a fault in it, but we're a system group, so we look at things from the system level. If you put a person-centered lens on this, then there needs to be sensitivity, there needs to be understanding of the wide range of people and their capacity and ability and even desire to look after themselves and to take more responsibility. So that holistic view has to be taken. I completely agree with you, Sam, about the peer approach, health champions being alongside people saying, I tried this and this worked for me, rather than the top-down approach. And I'd just like to say that the system talks about outcomes. People talk about outcomes and the experience of that outcome. We must never forget that.
Thanks, Ian. Very, very helpful. Should we move on to Sam, and then do stay with us, Ash, in case there's any further comments.
Will do.
Thanks, Sam.
Thanks very much, Chair. So I'm not going to take too much time because you've had the slides already, but I just wanted to perhaps talk around perhaps some of the challenges that we might go through over the next few months. So it was a year ago, actually, when I took a paper to the Integrated Care Partnership on smoking, because I wanted to make the point that it's not just a public health issue, it's not just something the public health team do. I wanted to provide a place where we could also recognise some of the amazing work that's happened in the hospitals, which sometimes probably doesn't get the airtime that it deserves, but actually Dorset's done really well as being one of the few systems where we do have regular screening of everyone who's admitted to an acute bed in the Dorset system. People are offered nicotine replacement therapy immediately, and they're also then offered a chance to have a conversation about whether they actually want to think about quitting over the longer term. So I'm going to present an update on some of that data to you quite quickly. But just to go back to the conversation about metrics and what are we doing as a system, the reason I came with this issue back in October was because the national ambition was to go smoke-free by 2030. What does that mean? It actually means getting the population prevalence down to 5%. That's basically going down to only having about 35,000 smokers left in the entire population out of 800,000. We reckon at the moment we've got about 70,000 smokers in the population. So actually it's quite achievable. And we're going to probably do that through a combination of offering connection to service and support. But I want to show you some of the data today which comes through from trying very, very different approaches and how we're reaching a very, very different group that we've never seen in smoking cessation services before. And ultimately, I hope that the Tobacco and Vapes Bill will provide another big societal push to really change behaviour and to kind of get rid of this issue once and for all. And unbelievably, even though I've been working around smoking for more than 20 years, it's still the single biggest risk factor that contributes to the largest amount of disability adjusted life years in the population. I mean, obesity is important, hypertension is important, all of those other things are important, but tobacco is still accounting for a significant amount of disability and disease in our population. So I hope you enjoy some of the progress that we're making. But as I say, I'll whiz through this. So for those of you who've not kept up, the tobacco bill that was going to be timetabled by the previous government is going to come forward again. It was due to be timetabled for early October. I've not actually kept up to speed with this, but I think they're trying to find parliamentary time for it. It's going to have a bigger push on vaping rather than just tobacco. And I'll talk about some of the cultural challenges around the really delicate balance between vaping as a really, really important tool to get people off cigarettes, but a really, really bad thing for children and young people to be taking up. And increasing evidence as well that there are some young adults taking up vaping who've never smoked before. So it's a really difficult and delicate message. This is just some updates on where we've managed to get to. We've retendered a lot of our community smoking cessation services, and we've actually managed to increase the number of providers. So we've got good coverage right the way across the community. We've strengthened our smoking offer through Live Well Dorset. They're working really, really well in combination with a national programme called Swap to Stop, which offers adults the chance to exchange their smoking habit, if you like, for a 4-week supply of vape starter pack. And I'm going to show you some of this data now. So we launched this in March last year. We've distributed nearly 13,000 vape starter kits. The bit that I'm really interested in are the people who are definitely engaging in several sessions of support, because those are the people who are serious rather than just saying that they're going to quit and then receiving a starter kit. So more than 4,000 people have been engaging in several sessions of support, and of those we've got nearly 3,000 adults that have confirmed that they've quit, which is 10% of that target figure that we started talking about last October. So if we keep going, this is going to drive change. And the other thing that drives change in social networks is when someone that you go to the pub with says, actually, I'm stopping smoking now, I'm done with it, and I'm getting on really well with the vapes. That's often the biggest and most powerful predictor of change. But the thing I'm most pleased about is if you look at the take up across different quintiles of postcodes. So we basically divide our postcodes into the 20% of areas least and most deprived. You can see we've had 5,000 or so taken up by the postcodes that are living in the most deprived areas. We would never normally see these people in our standard smoking cessation services. They are, naturally the most resistant. They are the hardest to reach. So this is a really important change in the way that we've started to think about smoking. And I'm very pleased the government provided that additional money to enable us to do this, because for certain segments of society, that offer of a vape starter kit is a really attractive way of pushing people into thinking about quitting. That slide just basically shows that we've already met our smoking targets for this year as of Q1. So it's really turbocharged what normally would take us a whole year to achieve. This is just some of the marketing that we're doing on Facebook. We're reaching some impressive numbers. So 74,000 people clicked through on some of these organic campaigns. And that's some of the swap to stop stuff. Treating tobacco dependency is the programme that I mentioned, which is happening through our hospitals. So I just want to bring you up to speed with again, this is another way of reaching a very, very different group. And it's also, importantly, a way that we can achieve scale. So if you look at University Hospitals Dorset, first quarter of 24-25, 2/3 of inpatients were screened. That's nearly 11,000 people, and nearly 10% of those were smoking. So again, that's another way that we've been able to reach perhaps 1,000 people that might have had a longer smoking history. They tend to be older. They're not all necessarily coming in with smoking related disease, but they probably have been smoking for two or three decades. And as you can see through the kind of flow through the bullet points, we're managing to engage a significant proportion of them who are going on to actually achieve a proper quit and having regular ongoing support in the community. There is a big drop off. So we started with 1,000 patients and we ended up with 133 people quitting. But because this happens every single quarter, these numbers build up through the year. So if we can achieve 400 or 500 from the hospital programme, plus perhaps 6,000 or 7,000 from the swap to stop programme within a year, it would be reasonable that we could be reaching 10,000 people who could quit. And over the next 5 years, that gives you your achievement against the target. So I'm going to move on. Similar figures to Dorset County Hospital. I'm not going to dwell on those, but roughly we're seeing about 1/3 of the people who engage and say, yes, they'd like to explore quitting, actually going through and having several sessions and saying that they've achieved a quit date. This is what I would call small steps, but again, it's really important. When we first started talking to Dorset Healthcare years ago about the importance of tackling smoking in mental health settings, some of the comments we got back were, what's the point? Lots of people with long-term mental health conditions really rely on smoking. You'll never do it. It's impossible. It's just too much of a kind of crutch, if you like. Actually, although it is quite difficult work, I'd just like to show you that comment from one of the nursing associates who's been working on the wards, which I think is more powerful than the data. it just shows you the benefit of persistence, really, and listening to people, and perhaps spending a bit more time and taking a more patient approach, because ultimately lots of people don't want to smoke. This is a habit. It's a highly addictive habit. And when you really question them and really talk to them about whether they want to quit, most people do. So really pleased that work started in Dorset Healthcare. Smoking in pregnancy, we've had pretty good data for several years now. This just shows that we still do get nearly 10% of women turning up at the time of booking who are smoking, but by the time they're delivering on the ward, that's down to below 5% in Dorset County Hospital and about 5% in Royal Bournemouth. So again, some really, really good work happening from frontline professionals who are supporting mums to quit. Just want to go quickly on to challenges, risks and issues. I've talked about this challenge around vaping. We have quite a variation between the two hospitals in the approach to clinicians recommending vaping as a route to quitting. So one of the things that we could do as an ICP is to have that debate. Do we believe that it's a useful evidence-based intervention? And if so, can we provide a bit of challenge back? There are some clinicians who are very, very opposed to vaping. Even when we've provided very, very good quality trials with thousands of people within them, they're still reluctant to endorse vaping as a route to quitting. But the evidence is really clear. It's twice as effective as other forms of nicotine replacement therapy at a fifth of the cost. And it's a really, really good option for some people. It's highly acceptable for the people in the population who are smoking. And this is a concern to me that University Hospital Dorset spend 10 times more than Dorset County Hospital on vapes. That's a good thing, by the way. It's Dorset County Hospital that I'd like to see fall in line. I've had personal conversations with one of the clinicians over there. There are some very, very fixed views. Here's where, as a system, I think we could be more joined up and say, the evidence is clear. We shouldn't really be tolerating disagreement around this. So what can we do to kind of bring everyone in line? Because of public health disaggregation, we're going to be transferring the responsibility for commissioning the tobacco control work in hospitals to NHS Dorset, ICB. That work's in progress, but we thought it was too risky to go through disaggregation without handing that back. And then the final point that we need to all work on is make sure that we're capturing that data across the different trusts. Probably the biggest challenge going forwards is the disaggregation of a shared public health service. That's not to say that we won't still have effective smoking cessation services, but we need to work through how we maintain that focus across both councils. And this year in particular, we were supported by additional national funding. It's worth about £750,000 in total, which supports the activity that we're doing alongside the Swap to Stop programme. So you'll just have to bear with us as we work through how to get through establishing 2 new public health teams. The thinking at the moment is that we're aiming for stability. So many of those contracts won't be touched in 25-26. We're aiming to secure the ongoing provision of the Liverpool Dorset service. So I'm hoping we won't see too much disruption, but I hope as an ICP you'd support that stability first approach. And of course, we've got a spending review, which is coming down the track, and we need to keep a close eye on that to make sure that government maintains its very, very welcome spend in this area. I think that's all.
Thanks, Sam. And I think both presentations show that persistence pays, but also that looking at, approaching things differently, looking at the, the click-throughs from Facebook were really interesting. And if there's more that we could be doing in that space in the other programs as well. Okay, I can see I've got a number of hands online, and thank you for making it bigger so I can now see. I've got Andy and then David Sidwick.
I think David was first, actually.
Okay, David.
Well, thank you. And thank you, Sam. Thank you for the paper and to see the good work which is being done. I'd be very happy to join in a debate around the issue of vaping. You will know, because we've discussed it before, that leaving aside its equity for tobacco cessation. I'm really worried about the number of young people who are getting into vapes. I'm worried it's being used by those for nefarious purposes as an entry point in order to get contact with the kids. And I'm also worried about what we're seeing, not so much in Dorset, but what we've seen in other parts of the country is the adulteration of vapes with other substances, which is making them more risky. So I don't have an issue about vapes. I have an issue about the channels in which people are able to get hold of them. So maybe that's something which we could debate and even champion the government, because the idea that it is part of a proper cessation program, to me, it seems to make much more sense. So that's just some reflections. And also all power to reducing smoking, but I think we also have to understand the illogicality if we don't mention the fact that cannabis is one of the things which is smoked a lot in this country, and it's one of the things which kids are in treatment for the most. So there's an illogicality there which I hope the government grips as well and makes sense of. Thanks very much indeed.
Thank you, David. Do you want to come in with your point, Andy? And then we...
Yeah, thanks, Sam, and I fully support your passion for addressing smoking as the priority. It's a no-brainer from a health financial point of view as well. I'm disappointed that there's only 27 GP practices delivering smoking cessation services. I'd like every practice to be delivering it. It's a reflection of the inadequate resourcing that's there for the smoke stop services. And I think, perhaps we could prioritise it at a PCN level. I do share the concern around vapes. I think we've got a vaping epidemic, and my concern is we move from one type of social epidemic to another. I think we focus a lot on children and vapes, and they are a priority area of concern for me. But we also know that children look up to their adult peers. And so suddenly when it becomes acceptable for their parents to switch to a nicotine replacement vape, it's seen as normalising vaping. When smoking first came to this country, it was seen as a panacea for good health. Indeed, we had doctors prescribing cigarettes. And I worry about the long-term consequences of vaping. This is a very short-term new fad, and we don't have the long-term health outcomes. And I think it just seems counterintuitive to me that we're trying to stop people inhaling a noxious substance into their lungs by giving them another substance to inhale into their lungs. And the only thing that we're actually designed to inhale into our lungs is air. So, I understand the rationale behind getting people off of cigarettes because they're very dangerous, but I'm not convinced by doing that with the aid of vapes. And I also suspect that there's a considerable market for some of the NHS vapes that are being given out as well.
It sounds like we need to have a separate session on vapes, because it does sound like it's a big issue. And I guess, is that something that we could coordinate and convene?
I think they're all really good points, and it illustrates what I said right at the start, which is that this is a very, very, it's a delicate issue, isn't it? We are talking about a harm reduction approach for tobacco, but you're absolutely right. It comes, potentially at a cost. It's a very difficult space, and I think we could welcomely debate it. It'd be interesting to see what comes forward in the bill, I think, because there've been signals from the Chancellor that they may be looking at taxing vapes. But the Police and Crime Commissioner's point is absolutely well made as well. This is one of the ways that potentially vulnerable children can come into contact with, groups who are there to exploit them. So it's a difficult issue. Be happy to continue the debate.
Okay, well, thank you for Ash, thank you Sam, and for taking us through those. As I say, persistence and different approaches and person-centered approaches do seem to be making a difference, but obviously still some work to do. So thank you very much for that. Can I offer people a 10-minute break? Can we be back at 12 o'clock? Just a quick comfort break so we can then get started on our next session, which is about the voluntary and community sector assembly. So thank you. 10 minutes, back at 12. Thank you. So I'm just looking to see if people are coming back in online. We're just waiting for the last few people to arrive in here. Super. Well, we've got two more sessions. There's two more sessions in this next part here. The first is a look with our voluntary and community sector assembly. So if I can hand over to Charlie and Mark, are you going to share slides or you?
Yes, we've got slides coming, I think.
Okay. And if you would just like to reintroduce yourselves as you go through the presentation, that would be really helpful. Thank you.
So while we wait for the slides, afternoon, everyone. I'm Charlie Green. I'm newly appointed chair of Dorset Voluntary Community Sector Assembly. My day job is Deputy Chief Exec of Working for Active Dorset.
And good morning, afternoon, everyone. I'm Mark Sharman. I'm part of the governance board of the Voluntary Sector Assembly, and in my day job working for Help and Care. Just sort of setting the scene for our presentation, it was quite interesting listening to Ash's presentation that the organisations that we both work for sort of popped up on the integrated thing. And actually, we both, and we were just saying at the break, our instant thing was to sort of contribute, but we're not here for that. We're here as Assembly. And I think that's just part of the challenge around the Voluntary Sector Assembly generally, is about actually us trying to represent the broader sector rather than just actually our own organisations. Just Charlie.
Next slide, thank you. Yeah, so this is Mark and I's first meeting, and we thought it'd be useful just to give a picture of the Voluntary Community Sector Assembly. Those of you might be familiar with its formation, those of you maybe less so, and the journey that we've been on over the last 18 months. So the Assembly was formally set up in 2023, and it is a requirement and a responsibility to have VCS engagement as part of the integrated care system and to be an equal partner in the integrated care partnership. So it is a new entity. It has no statutory funding attached to it. We're very fortunate that NHS Dorset have contributed to supporting the Assembly to set up. You can see the timeline along the top of what we've achieved since we've been in place. So the formation of the governance board, which came into place in spring last year, and we started to begin to understand our purpose and our role as governance board members. And it's probably fair to say, Mark, it's been a bit of a challenging 18 months or so.
Yes, and we all signed up to go to one meeting per quarter, and I think we probably met weekly for the last year or so, because I think actually the whole thing, there's a lot of history, there's organisations, and I think it challenges the roles of organisations about how we actually engage in that broader family of voluntary sector organisations, which sometimes it's easier for the system to have it as a very neat entity, but the voluntary community sector is not a neat entity. It is complex. It's different organisations, different values, different cultures.
Absolutely, and yeah, we all act independently as board members, so we leave our organisational hats at the door, and that is incredibly difficult. But we've challenged each other, and we have an incredibly good group of board members that are able to do that. Some of the decisions we've made as a governance board haven't been easy, but it's with the values of having a truly independent voluntary community sector assembly that we've tried to stay true to. We have recently appointed a programme director. That is with thanks to the funding that we've had to kind of have some stability for the next 18 months. So that person will start with us in early December. So that's a really key step for the Assembly. In order for us to do that, we've had to set up a CIC. Those things aren't easy and have all gone alongside the roles that everyone plays in their day-to-day, and with the support of John Sloper, who's been acting as an interim programme director for us. Next slide, please.
we've got this slide, which is an unusual one, but Mark alluded to it just now. The structure, we've been asked about the structure for the voluntary community sector and the voluntary community sector assembly. And there isn't really a structure we can settle on, other than that we have been describing it as a galaxy, at which there is that centre that we're trying to create with the voluntary community sector, but that all organisations in the VCS are part of the assembly. And really our purpose is right there on the screen. So we are a facilitator of process to engage with the diversity and the breadth of the galaxy, which is the VCS. We are not trying to develop an entity that will be another infrastructure body or a delivery of a service as such. And I think that's been one of our challenges in kind of making that clear.
And then when just talking about that we're not going to be a hierarchical, rigid organisation. So whilst we're really pleased to have the funding, but actually what that gives the assembly is one full-time worker and a part-time support worker. There's different views of how many thousands of organisations. So that one person is going to rock up at all your meetings and just go from meeting to meeting to meeting, because that actually won't be the assembly. The assembly is about actually how we facilitate a broader engagement from the galaxy to contribute to your different conversations, rather than it just being set people that come into meetings.
So next slide, please. So some of the impact that we hope to see for the system, but also for people and communities. So our sector's had to change. So we've had lots of mentions this morning about the change happening in the system and the partnerships. And the VCS isn't immune to that. It also needs to change and adapt. So we have been trying to develop the trust and engagement from voluntary community sector organisations, understanding what the assembly is, what the assembly is about, how it will benefit themselves, their organisations, their communities. There's some sensitivity in the voluntary community sector, and I think we can be quite open and say that there's some sensitivity about the development of the assembly, where it could threaten other organisations that play a role, but we're quite open to that, and we're trying to find a way at which we can all work cohesively and sort of play nicely together, as we put it, so that recognising all of the strengths that different organisations bring, and enabling a bit some open collaboration and challenging conversations with that. And we hope that bringing those organisations together and broadening that diversity of the voluntary community sector will mean that we can allow for more investment at a very local level and invest in different ways with different sizes of organisation across the VCS, and perhaps maybe we have been able to before, and crucially using the infrastructure organisations to support us to do that. You happy? Next slide. So we just wanted to share one example of this, and it was mentioned earlier, Dorset Council, the Families First Children's Pathfinder programme. The Assembly's been supporting Dorset Council with this, and it is just an example that we wanted to share about how we hope the voluntary community sector assembly will develop. There's learning for us as we're doing this, but the way in which we've done this is that we've supported Age UK North South West Dorset. We've released a member of their staff to kind of lead this work for the VCS. So again, rather than us creating a infrastructure, a team of people that work for the VCSA, we're using capacity from within our sector and skills, and building that capacity to support with programs like the Family First Children Pathfinder programme, where there is a need to have some VCS engagement and supporting funding to reach communities. Next slide, please. So hopefully the aims of the programme, we're doing this work, what we're doing is trying to capture the learning of the unique role of the assembly within it. So Debbie, who's doing some of the work for us, is capturing that learning, and our plan is to create a bit of a case study so we can start to communicate a bit more widely about the role of the assembly, the role it seeks to play, what it's learned through doing this piece of work, which will help create a bit of a roadmap for how we might like to work going forwards. Okay, and our final slide is a bit of an open to for discussion really, and some questions. So Mark touched on it earlier about our ability to attend all the meetings. As you said, we'll have one full-time member of staff, hopefully a business support member of staff, and then 8 governance board members, most of whom have full-time jobs. And the demand on us over the last 18 months has been much more than that. So we need to evolve the VCSA and develop it a bit further and engage that wider galaxy to support us with attending all the relevant meetings, the different discussion groups that go on in order to influence the work and involve the VCS. And it could spread us really wide and shallow. Or we could focus on some key programs of work where we think we can maximise the VCS impact and support, and are best placed to support. And we do think there is a bit of a choice for us to make about whether we are a wide, shallow VCS and we cover a broad spectrum, or whether there are some key things across the ICP and the ICS programs of work where we should focus our efforts.
Thanks. Well, I was just going to say thank you so much. I mean, I think thank you for all the time that you've clearly put into this as individuals as much as anything else. And it's a really innovative model that you've created there. I think it is good to hear how you've kept it non-hierarchical, accepting the diversity of organisations that you support. And I like the way that you describe releasing resources from within the sector. So organisations, providing a resource, possibly like in the way of a secondment that might happen elsewhere, but really helping to embed resources into places. I think that's all very innovative working, and clearly, again, the example that you provided there is making some difference already. Anyone else want to come in? The challenge about how do you focus your time? I think that's the big question for a lot of us here. We're trying to focus on some programs because we know that those need to be focused on. Your sector partners will all be playing their role and continue to play their role individually anyway. So what is it that the Assembly can add? Sam?
Just a really quick thought in answer to that excellent question about wide and shallow or narrow and deep. I think you could probably do a bit of both. So I think as we go through that kind of strategy refresh, there's something about following in behind when we have the conversation about what are the really important programs in the system where we can actually add some focus. But I think there's also something about continuing to work on the culture and being able to sort of really be the standard bearers for involving people genuinely and bringing those voices into spaces where public sector organisations are transforming. So it's maybe something to think about, how much capacity would that require, or whether it's just a call out to organisations might be best placed to find people who can be in the room when that work's taking place. But I would say the Assembly, if we can use the Assembly to focus on some really key pieces of system work, that would be excellent.
Sorry, I can see Steve, you want to come in?
Yes, thank you. Really brilliant presentation. Thoroughly enjoyed it at exactly right level. Hi, Mark. Nice to see you. I think as on behalf of the Health and Wellbeing Board, this is a conversation we'd really like to take forward, because rather than make it an immediate response now, as in, yes, obviously we'd love to develop an ever closer working partnership, we need to feed this into the Thriving Communities model, particularly, that we're developing. But there are a number of other consultations that are going on as well, where we want to see voices embedded within communities rather than spoken to from Dorchester. And so I think this is something we should be taking forward to our different health and wellbeing boards.
Thank you, Steve. Anyone else want to come in? Paul?
Hi, both. Nice to meet you. I think I met Debbie the other week at a Pathfinder inductions session. And just to elaborate on the Pathfinder involvement of the VCS sector and the Assembly, the help has been really welcome. Thank you very much. We have invested hundreds of thousands of pounds into something called family network support packages, which is part of the Pathfinder minimum requirements set out by the DfE, and that is about family-led decision making. So having family meetings, wider family network, and supporting and facilitating those families to come to their own kind of solutions when there's concerns or need for support or sometimes risk. And we could have spent all of that money by creating new teams in the council. We've got lots of teams in the council and lots of people in the council, but we decided deliberately to engage with and invest in the VCS sector to do some of that work at the really early support stage, not later on. We're doing family-led decision making with child protection cases as well in the council, but at the really edge of early support, we've invested hundreds of thousands of pounds in the VCS sector to enable communities to support families in their localities, in the communities. That's what that's about. And your sort of conduit and helping us to do that has been really helpful. And we're sort of continuing to want to deliberately invest in and engage with the VCS sector. And indeed, it's part of our developing council plan right across the council to do that. So thank you.
Could I just quickly pick up on that point? I think because I've been supporting Debbie in that work, and because she comes from out of the children families sector, because she comes from Age UK, that was quite inspired in a way, because then it means you get a fresh look and face. But Charlie mentioned that I think we see part of our role as actually helping the sector play nicely together, and that's been partly part of the role is actually you've got that investment, but how do we get the sector to play nicely? And I think that's where we see, that's not a particularly professional term, but we like it, but it's just a way of trying to create that better culture of partnership working, collaboration.
Yeah, collaboration, no duplication sort of thing. Absolutely. Kathy.
Yeah, I think it would be really interesting in terms of the priorities from the ICP through health and wellbeing boards in terms of place delivery. And I guess my curiosity is around how do we ensure equitability across the whole of the Dorset conurbation and not be driven just by finances, because we may, because of not being a pathfinder and not having access to the funding, is how do we ensure that BCP children, it isn't a postcode lottery in terms of some of that delivery. And I don't think it's just for that. I think it's a wider question for us as an ICP delivery in how we manage that. And it is also how do we take the best practice, which is obviously happening in Dorset and that national programme, and deliver that across the system. And that question, in essence, that funding will run out in March next year to a degree. And so how do we promote that sustainability so Dorset enables to continue that good work, but that good work also is then distributed across the whole of the Dorset conurbation. So that, yeah.
Absolutely. And the other question I wanted to come in, so grants, I mean, you know, it's voluntary sector organisations are really good at pitching for grants. You know, that's their lifeblood. Is there anything else, anything more that we could be doing together on accessing more money to feed into these programmes in the system from other places? I mean, is that something that you think the Assembly can help us with?
Yeah, it's a good question. I think one of the benefits of being and with Mark and I probably both experienced this in our work with our work hat-ons, is that you can access funding that you otherwise cannot. Yes. So I think there is definite opportunity to work together as system partners around some of the core priorities in our shared work plan for our Dorset, where there might be an opportunity for VCS partners to be lead bid organisations, and the Assembly can play a role to help organisations collaborate. I think that's where we see the role of the Assembly in terms of supporting the VCS organisations to collaborate around priorities and deliver work together, playing to their unique strengths, which would be different.
And obviously the businesses who have social funds available, again, working with VCS is much easier than it would be to trying to provide money perhaps to the NHS or to the council. Again, another opportunity for us to be working more to say, you know, how can you lead some of that work with partnerships?
Yes, and one of the main drivers for the Assembly is about how we can support a culture where money is getting down to smaller community groups, not the likes of who we work for, but actually community groups. And actually, it's been really interesting to work with Dorset on the children's families work, is that we're not going to get into the game of distributing money and be a conduit for that, because there's other people that exist that can do that. Our job is to help facilitate the process where investments in community can happen much more effectively, if that makes sense. We're just very clear that we don't want to become the body where money is parked and then we have to get it down and do that stuff. There's other people that can do that, Dorset Community Foundation, etc., etc. Yeah. But actually, how we get investments in communities to actually be part of some of the stuff we've heard earlier, I think is a crucial role of the Assembly.
Thank you. Yeah. Leslie, can you put your...
Just coming back to the broad and narrow, just kind of coming back to what Sam was said and actually a colleague from BCP about, I mean, we can't do everything for everyone. I think we're all aware of that, really. And I guess we're all trying to sort of use the dice to focus in and have targeted interventions. I mean, from my, same, we can't do everything for all students. No one can do everything for all citizens. So I guess with the resource that we all have, there have to be choices around where we most target that resource, and I guess that the dice is helping us find those areas. So, there will be things that will appeal across the board. But we've had recent discussions on oral health. Well, we know we're not trying to develop services for probably people around this table. Frankly, this is about people that actually can't access services or can afford to pay for. So I think I come back to us. I think there must be targeted areas around the priorities and neighbourhoods and localities that I would have thought must be screaming out for support more than other areas where there could be issues, or whatever. But actually, they're either that the capacity for self-activation or self-management is higher, or for all sorts of reasons, financially they're higher. So I guess that's my appeal actually with what we've got, and this is incredible. I mean, amazing the way that you've drawn this together. Really congratulate you, and it's the manner in which you've done it clearly has been incredibly successful. So that's testament to, I think, the people involved. But I think I'm not sure we can be entirely equitable. I don't think it's a universal offer. I think it's a very targeted offer that's coming on all sides. And that sort of, if I call it bottom up, and I don't mean that rudely, approach is obviously, we know that's really incredibly important. So yeah, thanks.
And the work of the VCSA doesn't actually stop the work that's obviously going on with all those voluntary organisations on the ground anyway. So they will continue doing what they do on the focus areas that they have chosen. So we don't direct that work. That's their bit. This is our opportunity to direct some of it in our focus areas. So right, yeah, Kelly.
Hi guys. I just wondered, Community Action Network. I wondered why they're not listed as a governance board member. They feel like an important partner in terms, certainly from a BCP perspective, in terms of the VCS.
Yeah. So Community Action Network is involved. So there was a model within an engagement group previously. When the governance board came into position, we all went through an independent recruitment process for board members with an independent organisation. I can't remember what Devon, Cornwall they were from.
There were people from Devon and Cornwall, so we all applied, and there was an independent appointment that has appointed all the board members. So that was the process. CAN and Help and Kindness were the engagement group. The governance board had taken a view that actually we have a program director and actually use the Galaxy approach of actually utilising lots of different organisations, of which CAN, Help and Kindness, Dorset Community Action, Help and Care, whatever, will be part of that Galaxy, but actually not just one organisation, if that makes sense. And that, and there are different planets within a galaxy of different sizes, and so therefore we need to utilise them all.
Thank you. Who knew we were going to have so many conversations about space? Can I take the last question from Sarah?
It's not a question, it's just picking up on the opportunities to work together. So in my role as lead for the Dorset Innovation Hub, we have many partners represented, including Dorset Police and wider across the local authorities. And what we've done is work with the VCSA, and thank you, you are one of our founding partners in its original form before it was obviously the formal formation. But how we're working together, so within the ICB, looking at the inward investment team, how actually charities can lead on grants, and we have the power of the organisations working together so that actually with letters of support, we are able to draw in wider funds, and that's really, really important. So with the ICB, with something called REN 3, we're working with homelessness, with 2 of the different charities, how actually we're supporting and enabling that funding coming through for activity, research, engagement with homeless people. So it's the opportunities are there, and perhaps it could be tabled for a discussion at another point. Thank you.
Well, in the interest of time, I would just say thank you so much. I mean, it is great to hear how you've managed to get through and get that governance structure. I mean, it's clearly very complex, but the fact that you've been able to do it in such a way and keeping it open and keeping it playing nicely, I like that term. So yeah, absolutely. Thank you very much indeed, Charlie, and thanks to Mark. So our last item today is looking at what's called targeted winter support. It started, I think, I asked a question of Sam and John Sloper as to, well, what are we doing about individuals who may find themselves in fuel poverty this year? And I think as a result of that, I had an answer from Aidan from Dorset Council, but then was pointed in the direction of Rob and his team and the work that they've been doing with DICE. And I think what we'll see here is a great example of how we can use the data that we have in the system to build what could be a great programme to support those individuals who are affected. So I'll hand over to you, Rob. And would you like to just introduce yourselves and your team?
Of course. Good afternoon, everyone. I'm Rob Dabbs, and with me today is Izzy Webb, and we have Scott Francis Mitchell at the back. So any difficult questions will be directed to Scott as he pulled together the analysis. And we work for the DICE, the Dorset Intelligence and Insight Service. For those not familiar with it, essentially the DICE brings together multiple data sets from health, social care and wider determinants. And we put it through a pseudonymisation process so we can't identify anyone, and it helps us understand our population and clearly to deliver targeted interventions. And I think it's a great demonstration of the capability of DICE today. So as you've mentioned, this project did start as a plan on a page a few weeks ago, a bright idea, but we've been able to provide an initial assessment of the scale of the challenge that presents to the most vulnerable within Dorset. And before I start the presentation, I just want to thank Dorset Council for the additional data sets that have been provided, specifically from Pete Jackson. In addition, John Sloper, it's been really valuable in getting his feedback as well. So bringing us on to why does this matter this winter specifically? In 2023, all pensioners within Dorset would have been in receipt of a cost of living winter payment and a winter fuel payment. However, this winter is different, and only those on pension credit will receive a winter fuel payment. And we know the issue of cold weather exacerbating medical conditions, which increases the demand on all of us in this room. So significantly, 24% of the Dorset population is at pensionable age, and we've identified 1 in 5 are exposed to being financially vulnerable this winter, which is approximately 43,000 people across Dorset. The goal of, I suppose, this project is to deliver targeted interventions to reduce the pressure on the system and try and support those most vulnerable in our communities. And as I'm sure we'll all appreciate, prevention is better than cure.
So I'm going to come on to describe the challenge and the size of the challenge. So first I'm going to describe kind of the risk, the population that are at risk. So as Rob mentioned, in 2023, so last year, around 200,000 Dorset pensioners received the winter fuel payment and a cost of living payment. This year, in 2024, about 20,000 people, so 10%, are likely to receive a winter fuel payment. So cost of living payment kind of is no more. We've then done some analysis using, as Rob said, kind of the local authority data sets and the other data sets within DICE, and estimated that around 43,000 people are at risk of being financially vulnerable. So 43,000 pensioners are at risk of being financially vulnerable this winter. So that presents us with a gap of around 23,000 people who likely will not have financial support this year. Coming on to kind of look at conditions that can be exacerbated by cold weather. So as we age, the likelihood that we will have one or more long-term health condition increases. We've come on to look at what are the top or primary long-term health conditions that affect pensioners, and they are the 8 at the bottom of this slide. We've then done some additional research to look into which of these conditions are exacerbated by cold weather, and 6 out of 8 of them, so those in pink, can be made worse by exposure to cold temperatures. So we're looking at hypertension, depression, coronary heart disease, atrial fibrillation, asthma, and COPD. So that's 2/3 of them.
So coming on to our approach, as I previously mentioned, what we did was combine multiple data sets together using both local authority data and already health data within the DICE. So we've been able to adjust our logic to identify those that are financially vulnerable. And what it's allowed us to do is create an intelligence picture and identify those most at risk. And these include whether they are financially vulnerable, whether they have long-term health conditions, or whether they have some form of adult social care support. And our focus on using this intelligence is really to, I suppose, to achieve 2 interventions. One is targeting high-risk communities, and we've already identified 20 priority wards across Dorset where the most pensioners reside. And then also at an individual level, we can use the re-identification tool within DICE. So this would allow GPs, social prescribers, potentially social workers to re-identify at an individual level and contact those directly affected and intervene early.
So coming on to some key objectives as well for this project. So bringing to life kind of what Rob's describing there, we've mapped where pensioners at risk are across Dorset. So they are shown by the blue dots on the map to the right of the slide. So these are residents aged over 66 who are at risk of financial vulnerability. We've used local authority intelligence to be able to do that. Secondly, we've then overlaid NHS data to see of these people who has one or more long-term health condition. That means we can just seek to prioritise those people. And then thirdly, again, as Rob mentioned, we found these 20 priority wards that are shown in pink, where we can look at the highest concentration of these people, so lending itself to some of those targeted campaigns and sort of basing those within these areas.
And I'll briefly cover the current DICE tool. So this is still under development. We still need to put it through some vigorous testing. However, it will give you an idea of how to utilise and engage with it. At the top of the report, you have all of the filters where you can drill down via ward level through to PCN, even GP surgery, long-term conditions, whether they've got adult social care support. So being able to really focus that intervention. The top sort of call out cards are the significant numbers that we need to be aware of. So as I mentioned, 43,000 potentially at risk. And I think it's 91% of those have a long-term medical condition. Interestingly, it's an even split between BCP and Dorset Council, 50-50. And we've identified almost 2,000 pensioners that have some form of adult social care support currently. That are within that cohort being vulnerable. The bottom left essentially expands on what Izzy's just covered in terms of providing a geographic view. John Sloper has kindly offered to provide additional data so we can overlay where warm spaces, warm hubs are already available, just so we can identify where there are any gaps potentially. And the bottom right chart on this essentially plots all of the wards by population size and by the percentage at risk. So the top right quadrant is our 20 wards that are the priority area, because that's where most vulnerable live.
So I'm just going to come on to describe a couple, and these are, examples of some of the healthcare impact that people accessing healthcare services may need if they are presenting themselves to either primary and secondary care. There are further conclusions and analysis in the accompanying paper, but some key headlines. So if we come on first to look at the effect of primary care, so looking back at last winter in 2023, of these at-risk residents, so pensioners aged over 66 at risk of financial vulnerability, if they visited their GP once last winter, they then on average went on to have 5 further GP appointments before the end of the season. So if we could encourage GP surgeries, social prescribers to actively engage with some of these people, proactively engage with some of these people, there is a potential to save future GP interactions and appointments. Coming on then to look at some of the interactions with sort of secondary care health services. So we began to analyse they're called key complaints, but kind of reasons that people would present to either an A&E or an ED department. And we found that chest pain and shortness of breath account for 20% of all A&E attendances and 30%, so just under a third, of all admissions to hospital via ED. Crucially, both of those conditions are likely to be exacerbated by cold temperatures and prolonged exposure to cold temperatures.
And finally, to provide some sort of, I suppose, light at the end of the tunnel in terms of potential savings this winter, looking at our acutes, which are already under significant pressure. This cohort last winter, between October and March, on average spent 7.5 days as a non-elective spell in our acutes. So if we quantify that and potentially look at admission avoidance, it gives you an idea in terms of the number of bed days potentially we could save in our acutes. Of those cohorts, 8.5% were admitted to hospital last winter, which furthermore provides potentially, if we can avoid these emissions, it would reduce our admissions by 21 per day across Dorset, which is quite substantial.
So we have come up with some proposed interventions and some recommendations, some of which we've already referenced throughout the presentation. So firstly, we think there could be an element of kind of this data-driven targeting, so using the DICE tools that are already exist and the new one that's kind of being built to identify the most vulnerable pensioners across Dorset. Next, we think there could be some collaborative efforts. So I've already mentioned, GP practices, social prescribers, digital care coordinators beginning to use the DICE tools. And I'd like to just highlight there that many of these colleagues are already familiar with DICE products and are trained on using DICE tools. So the knowledge exists there already. It's kind of just a new report or a new kind of way of identifying them. Thirdly, there's the warm spaces campaigns that we've already mentioned, so increasing awareness of those warm spaces that already exist across the county. So they range from libraries, community centres, churches, so just increasing the awareness of those. And then fourthly, coming on to expand some of the work that's already been happening at Dorset Council to use Internet of Things sensors that with consent can be placed within people's homes to collect information around kind of movement, room temperatures, has someone popped the kettle on that day, those kinds of things to just sort of check in at a distance whether someone's kind of doing okay, and then seek to intervene early before, perhaps that fall or etc. has happened.
So coming on to the way forward, and I suppose how this aligns to our system strategy, I think it's fairly self-explanatory in terms of how it delivers against the ICP objectives in terms of that targeted intervention, which is all about prevention and early help, utilising the already well-established voluntary and community sector across the system to help support our communities thrive, and finally, obviously, working together collectively as a system. It also meets the Joint Forward Plan Outcome 4, which is supporting older people to live well and independently. And I suppose finally, if I look at working better together, to reiterate, this project is not about data. We've provided the intelligence, and it's now upon us, or within our gift, I suppose, to deliver these interventions. And most importantly, it's how do we collectively have that shared accountability, shared responsibility as a system to support those most in need. And just to reiterate, together, we can already reduce pressure on the system, and that's primary, secondary care, as demonstrated, prevent those hospital admissions, and most importantly, it's improving the quality of life for our most vulnerable citizens. That concludes the presentation. Are there any questions?
Thanks, Rob. It just does show you what the amount of data that we have, both in local authorities and in the DICE system, how we can use it, how we can use it to shape those prevention programs. So I think it's really powerful to see it presented in the way that you have of the sort of thing that we're able to do. So does anybody want to? Yes, Manco's in there.
Thank you very much, Emily. It's very interesting and great to use data. I mean, do you think there's something we can do to help older people who are not very familiar with technology, who may want to sign up for pension credits or may want to navigate through that complexity?
Absolutely. I know Dorset Council are running a campaign to encourage people to sign up for pension credit. And I think it's about how do we collectively communicate the same message to the population. We do have a DICE report which highlights those that are digitally excluded, which is around, I think, 30% of that cohort of people. So absolutely, we can target those individuals that are not digitally enabled yet.
I mean, this presentation is more to let you know that we have, I think we have the data now for anyone who is wishing to try and roll out some programs locally, or put in place some additional supports. The data is here to help target that. The fact that we can work to, what is it, not anonymize, what is the opposite of anonymizing, but get access to that data again, should that be something that people require. Presumably there are processes one has to follow in order to do that, but clearly that data is available to us. Yeah, I think Richard was next. Richard, so yes.
Thanks, it's Richard from University of Dorset. So great work, and we've seen other DICE things today, which has been brilliant to get the analysis. This is on Mosaic, so it is an assumption of need. But are you saying that we'd actually be able to get individual case finding down to individuals? Because it feels like rather than run broad campaigns, we probably need to do the pension credit sign up as a key intervention. But are there any other evidence-based interventions for this cohort that we could, target down to the ward and the specific area? Because I suppose that's the call to arms. We've got the data. What do we have the right interventions for this particular cohort? Thanks.
I wanted to come in.
Yeah, it's a really nice example. Thank you. I think what's interesting about this and about your question, Richard, is that we're not yet fully in the habit of working as a system, are we? You've got a brilliant conduit where you could DID and re-ID potentially eligible people for a whole range of interventions. I know that we run the Healthy Home Scheme, for example, across Dorset, which offers upgrades to people's homes to improve their energy efficiency and their kind of the warmth of those. But there's also things like Household Support Fund 6, which we're due to kind of make some decisions on as to how that money is going to be used up until March 25. So I suspect loads of different agencies have got lots of different interventions. Could we establish some kind of inquiry service, I guess? And is that what you're offering, without putting you on the spot? That we can come to you and say, we think we've got something that could be targeted. Can you help us find recipients?
Absolutely, and that is the whole purpose of DICE, to improve our population outcomes. So I think this is building upon a specific scenario and situation that's occurred quite quickly, and certainly there are more use cases that we can roll this out to.
Can I ask? Sorry, Kelly. And then
Thank you. Just to pick up on the point about the household support fund, so there are grants, certainly in the BCP area, that are available of £200 per household, obviously subject to financial assessment, and we've got CAB supporting us with that. But it would be really helpful to think about that. You know, it's only as good, you know, these programs are only as good at getting to the people that hear about them. And the other thing just to say about the household support fund, because that is a considerable fund, 2.6 million just in BCP. Not sure what the number is for Dorset, but we're at the moment we don't think that will be continued. So a lot of we're waiting obviously for the spending review and for budget announcements, but that's a really significant risk in terms of some of the support that is available currently. Families, children, there are a lot of elements to that will be a risk to both areas.
Thank you. Sarah and then John.
Thank you. Just really quickly, with DICE, obviously it's fantastic to see this, but from a perspective with a bit of an analytical head on, it's thinking about, we know about this information, we've got a duty of care to action. And I wonder, Ash presented, and on the slides were the networks, and there's the Ageing Well and Frailty Network. And I wonder if this report, this presentation, recognising it's making certain assumptions, goes back to that network. There is a new clinical lead, I think it's Sarah Patterson from Dorset Healthcare, and it's pulling together all key stakeholders from the local authorities. So Dorset Council was Sarah Parsons. I do apologise, I can't remember who it was from BCP Council, but to highlight, to surface, to join the dots and see if actions do need to be taken.
I think that's very helpful. It is trying to find the home for that work. So that's a good call. John.
I just wanted to say what a brilliant piece of work. I think it's quite amazing to see, probably for the first time in this system for me, how this product is allowing us to target finite resource. So I think bringing it here and then for people around this table to work out how you use it is really is powerful. So great work.
As I say, I was very excited when I saw the fact that just asking a question of the system created such a really useful set of data. And as we're saying now, how we use it, how we target it, how we use the wonderful insights you've come up with and suggestions. I think this is going to be the first of many questions I think we're going to be asking of the DICE system, and hopefully utilising data in this way. So thank you very much. Unless anyone else has got any more questions, I don't see any online. Thank you very much. Okay, thanks. Okay, so do we have any questions from the public? No, we have no questions from the public. So do we have any other business? David Sidwick.
Thank you. It's kind of related to the last presentation in it's about the use of data. I'm trying to get a real handle on violence and how to reduce it in Dorset. And we're aware that the police obviously have their reporting systems, but there's also what happens in the emergency rooms, which we don't have an equivalent sight of, because not everything gets reported to the police, if you see what I mean. And I think there's a difference between the hospitals and how they share their data. And I'm not asking for this board to look at it. I'm just asking to understand who we should talk about in order to try and get that understanding. So it's use of data again.
Thank you. Sarah wanted to.
If I may just respond with Dorset Police as members of the Dorset Innovation Hub, we're working with Chief Inspector Danny Tamlin, and he's looking at the use of DICE data with Kim Ward and looking at the uses of information to triangulate. We've started with nutrition in ageing people and looking at triangulation of 999 calls, fire services, attending the ED departments. So we're looking at accessibility from that perspective. So I understand that Dorset Police are working with the DICE team to be able to take that forward, and I'm getting nods from Rob.
So it sounds like that work is started, but I mean, violence, I guess, is another aspect that perhaps could be
multiple aspects.
Sam.
Thanks, Chair. Question to Richard, because I don't know the answer. Does your ED still collect data to run the Cardiff model?
No idea, but I can find out.
So Cardiff model is basically a data set that emergency departments collected in response to people who've come in with facial injuries, usually arising from, glassware in the nighttime economy. We did have a very good model a few years ago where we could share that data across both council areas, but I think it's drifted post-COVID.
I don't know if David Clayton Smith is still with us, whether you wanted to mention anything about your creative health. I don't know if he's still with us, or is he gone? He's not online. Okay. Well, thanks, everybody. Liz, did you want to go through any of the key messages that you've highlighted, or anyone that'd be really helpful? That would be very helpful. Thank you.
So the key messages that I pulled out of the meeting for today were that we'd agreed the terms of reference in the work plan, and that we had welcomed the Office of Executive Support from the ICB Deputy Chief Exec Officer. We really welcomed hearing about the local authority work in the round and how helpful that was, especially around the co-design, the partnership working, and the alignment with the ICP strategic principles. We reiterated our commitment to CBD, respiratory and falls as priority areas for us, and really wanted to focus on the importance of remaining person-centred in that work. We welcomed the good, sort of put my specs on, it would really help, the good progress around smoke-free for 2030, and agreed to have a further conversation about a system view on vaping. We really thank the VCSA for their presentation, and we were considering whether that was going to be a focus broadly on the full agenda or more deeply on key issues. And we really welcomed the work and the demonstration about how DICE data can be used around the targeted winter support for vulnerable pensioners. And we considered the 4 sort of recommended interventions that have come out of the presentation today from the team.
Thanks, Liz. I think that's very comprehensive, unless anybody spots anything else. We've got a few minutes left, which we rarely do at the end of one of these meetings. So if anyone has any feedback on these meetings, anything else that we should be including, I know, Leslie, you mentioned workforce and making sure that's covered. It'd be interesting to hear a bit more about skills and the roles of university and research, and some of them, we clearly got some tangential messages in that.
FE as well, so I think it's that escalator which we keep talking about, how we get people in, but we probably need an 18-month lead in to do that properly, really. I guess that's key.
And the other thing I would mention is that obviously we have an economic growth strategy that is being out for consultation, that was coordinated by the LEP on behalf of those local authority areas. If anybody else would like to see that or contribute to that, again, it's another part of developing our economy. It's, yes, we have to build an age-friendly community, but we also have to build communities that are going to be friendly to that future workforce, because that future workforce is where our prosperity is going to come from. So any reflections, anything else that anybody thinks we should be doing more of? I'll get into trouble if I do more. I think we're trying to focus it. No? Okay, well, thank you. Just to say thank you, everyone, for joining and for all the contributions. It's been, I think, a really, really useful meeting, lots of discussion. So thanks, and thank you to everyone online for joining us today. Thank you.